Welcome all to our second day of our Health Disparities Research Symposium, our fourth annual. And we've had a very exciting set of presentations yesterday and a lot of exciting conversations that went on for a bit. Michelle Burrows, I'm very excited to actually introduce her because for years she has been running the Center for Healthy Communities. And we were able to sort of unifying field theory, bring her on to run also the Community Engagement and Dissemination Core in the Health Disparities Research Center. So all is aligned in the universe, and Michelle's making sure it happens. Okay. All right, so I'll have Michelle then introduce our speaker.
Welcome, everybody, to our second day of our symposium. I'm so glad you are here to join us. And I'm so glad to have the privilege to be able to introduce our speaker. I have worked with her on several community projects, so I know she's very passionate about health disparities, and I thought that she'd be a great individual to come and speak to you about local challenges that we're experiencing as it relates to health disparities. So Dr. Marshare Penny is a Deputy Director of Public Health with a special focus on health equity for the Riverside University Health Systems. Public Health. She has 20 years of experience in community and public health, with 10 years serving as a local epidemiologist in the Inland Empire. Her training and experience has been used in the outbreak investigations as well as in the trending and monitoring of injury and chronic diseases. Her research interests include the areas of health disparities or health equity, social determinants of health, epidemiology, disaster preparedness, injury, and violence prevention. Marshare is a clinical professor of public health and former chair for the Department of Public Health Sciences at California Baptist University. She earned her DrP in health promotion from Loma University, fellow alumni, yay, and an MPH in epidemiology from San Diego University. So please give her all of your attention, and I'd like to welcome Dr. Marshare Penny.
Thank you so much. All right, well, good afternoon. It is a pleasure to be here with you all, and my apologies, I'll do my best not to turn and look over my shoulder just to make sure I'm on track. But I'm excited to be here with you all this afternoon and talk a little bit about health disparities. When Michelle and I spoke and she asked if I'd be available to speak today, I thought, oh my goodness, for an hour, okay, what am I gonna talk about? How do I talk about health disparities? How do I talk about the great work that's been happening in our county, but also a lot of the work that we still have to do? And then I realized, oh, there's an hour is not enough time to talk about health disparities and all of the great work that we're doing and still have to do in our county. So, but I wanted to set the tone a little bit for you around some of the things we'll get to talk about. First, sharing that I have no financial or non-financial disclosures to share with you all. And a little agenda for you. So what we're going to cover in our time, and I will look at my watch to make sure I keep myself on time because I can just keep going and going. And in this room, I see a number of familiar faces and friends that I work with and I've worked with over the years. So I get really excited to talk about health disparities work, especially in the context of the work that many of us in this room have done with each other and the shared space that we have today. So I'll start with talking a little bit about who we are in Riverside County. And then I want to talk about health disparities really as the what I call the persistent and pervasive case of health disparities, this long and ongoing thing that we know exists. There's no question anymore about whether or not health disparities are real and what the causes or root causal factors to health disparities are. I'll also then move us to looking at what are some of the ways in which we address health disparities, how we've historically addressed them by looking more downstream, but getting us to focus more on upstream. If you haven't heard about upstream approaches, I'm sure I'm in a space with friends and believers in this work, so it's probably not unfamiliar to hear upstream approach, but I'll still highlight some of the important ways in which we need to focus more upstream and move upstream in our work around health disparities. And then I'll talk about how in Riverside County we are moving upstream and just give a few examples of the work that's being done. Upstream approaches are challenging. It's tough work, but it's important work. And so there's a number of things that we're doing, but we only got enough time for me to highlight three. So I'll highlight some of the three areas that we've been focusing on most recently around addressing upstream approaches to addressing health disparities. So I promised an introduction about who we are in Riverside County. So just to set the tone, I like to describe our county as a worker in our county. So I'm a deputy director for our local health department. I support our infectious disease, community health planning, and equity division in our health department. We're divided into 3 divisions. And we have a maternal, child, and family division, which is overseen by a colleague of mine. And then I oversee the infectious disease, community health planning, and equity. So that's where our health equity work is seated within my division. And I serve as the equity and justice officer for our department. And so we work on, we have our health equity program, which I'll talk a little bit more about, highlighting kind of where we've come from and how we've landed where we are with our health equity work. But also thinking about how we embed health equity in all the things that we do across our department. It's not just seated within our health equity program, but we've got a number of programs and services across our department where equity work has always been happening. We have a name for it now, and we get to highlight the work that we're doing, but also look at ways of improving that work that we're doing in our county. So I like to describe our county because of the work, we cover a pretty expansive geography. We're a county of about a little under 2.5 million. So we're just over 2.4 million residents in our county. We're actually, in terms of population size, if you didn't know, we are the 4th largest county in California and the 10th in the nation. So we've got some street cred. We're a good sized county. We are about 7,200 square miles. So that's pretty expansive. It's 4 hours one-way drive from the west end of our county out to Blythe, which is the farthest end of our east part of our county. So 4 hours one way to get out there to support our desert, our partners out in the desert. We're not the largest, though. San Bernardino County has got us made, with being the largest county in the contiguous U.S., over 21,000 square miles. But we're close. We're close with that. We also border Orange County, we border San Bernardino County, San Diego, Imperial County, and Arizona border. So I highlight that just so you can see kind of the vastness of our county, and that ultimately highlights the community that we also support, and that we all live, learn, work, and play in this space. We're also home, for those that are not from California, I always tell them, hey, and you don't know where Riverside is? We are home to Palm Springs. We are home to the resort town Palm Springs. We're also home to the Mission Inn, where we hold a Festival of Lights every year. So let's travel from all over the world. All over the world. I am always so amazed to learn folks who travel internationally to come to Riverside to see our Festival of Lights. I was like, okay, we welcome you. We welcome you to come to our town. So that's a little bit about kind of who we are as Riverside County before heading into outlining some of the challenges that we see in Riverside County around health disparities. So there's a great resource tool if you haven't had an opportunity to use it. This was created, it's called the Healthy Places Index. We use this a lot in public health. In the public health space and sphere, we use it a lot. And it was adopted throughout COVID response as well to help us characterize communities in need and of need around vaccination work. And it's still used. I mean, we use it for so much. We use it for most of everything that we do when we characterize community need. But the Healthy Places Index is a measure that looks at social factors. So it's great to look at health outcomes in our community, right? To know who's at greater risk of heart disease, who's at greater risk of stroke. But what you and I probably want to know more of is what contributes to that greater risk. So what are some of the challenges that our communities are dealing with that increase their risk of heart disease and stroke? And that's what Healthy Places Index helps us. It's a tool, among others, that helps us really characterize, to learn a little bit more about our communities around transportation challenges, food, housing challenges. Those things are measured using the Healthy Places Index. And this system takes the data for your county and for census tract and city level, and it highlights the data using what they call quartiles. And quartile 1 is the most disadvantaged quartiles in your community, all the way up to quartile 4, which is more advantaged. Okay, so I just set that tone so you understand what Healthy Places Index data allows us to look at and how we use that data. So when we look at quartiles and we look at our score, you can score up to 100 in Healthy Places Index. And as you can see on the screen, we are scored at 39.3. We are ranked in Riverside County as 35th. Out of the 57 counties that have data available. There are 58 counties in California, 61 health jurisdictions in California. Of the 57 that have data available, we are ranked in Riverside County as 35th. That means there are 34 other counties doing better than we are. when we look at the measure of healthy places. And to add some additional context to that, and I know this may be challenging to see, and I'll make sure I'll share the presentation so that if you're interested in looking at these slides a little bit later, you're welcome to. So I love this slide. This actually was not developed by me. This slide was put together by our health officer, Dr. Jeffrey Leung. And so I asked him, I was like, can I borrow the slide that you used to show Healthy Places Index and how you're comparing groups? Because I think it says it perfectly. Why do I recreate what you've already put together and we've talked through? But what you can see here is our county on the far left. You see it says, in Riverside County, and this is a little bit dated, it's about a year old. That time we had a population size of 2.2 million residents. 871,000 of our residents lived in what we call quartile 1. So that is the most disadvantaged quartile out of those 4 quartiles that the Healthy Places Index measures. Okay. So then the next question is, well, how is that in relation to other counties? Right. So when you can see in the middle, there are 6 counties in California that have a large, and you look at their populations cumulatively, they have a larger population than we do, right? 5 times larger, you add them all up, you add all 6 counties together, 5 times greater population size than ours. They still have a count of fewer people that are in quartile 1, 838,000 living in quartile 1. When we look at this in terms of proportion, for us in Riverside County, 40% of our residents live in quartile 1. Those 6 counties have about 7.5% of their residents living in quartile 1. And then we move on to the third grouping. There are 17 other counties. When you add their population sizes together, they reach about 11 million. They still have fewer total residents in those 17 counties that are living in the most disadvantaged communities within their county, about 8%. So on average, we have more of our residents in our county that live in the most disadvantaged quartiles compared to 23 other counties in the state of California. We got a lot of work ahead of us, a lot of hard work ahead of us to support our community members and the communities in which we all live, right? I also have some data to share with you when we look at life expectancy. Life expectancy is an outcome measure. We love to look at life expectancy to really see what that looks like across our county. We've looked at it on average, what's our total life expectancy, and then we start stratifying by race ethnicity to see if there are racial ethnic differences, in which we clearly see racial ethnic differences. But here on the slide, what I'm showing you are geographic differences. And this actually is looking at location and income. We see a strong correlation, strong relationship between the community, the income of the community, and the life expectancy of the community. But what I want to bring your attention to is that with our lowest life expectancy, so we have a community with the lowest life expectancy in our county of 74 years. We then have a community, a city, that has the highest life expectancy in our county of 90 years. Okay, so that's a 16-year gap in life expectancy between those 2 cities, and those 2 cities are only 23 miles apart. This is not the 4-hour drive from the west end of the county to the east end of the county, and that's the life expectancy gap. No, these communities, these 2 communities in particular that boast having the highest life expectancy and one that has the lower life expectancy, they're only 16 miles apart from each other. They're neighbors. So I highlight that to highlight the place-based discussion, right? The discussion around where we live, work, and play, and how that influences our health outcomes. But there's so much more to that, right? We see those numbers, but there's more happening beneath the surface that contributes to those numbers. And then here's some data that our team has pulled recently looking at leading causes of death. So, COVID put a lot of things on the back burner, right? A lot of the data analysis that our team does a wonderful job of doing and pulling together, they are diverted to COVID work, right? Because we're all interested in what's happening with COVID, and so analyzing data, helping us look at identifying who needs to be vaccinated and where are they and how do we get to them. And so now we're able to start looking again at some of the data we've historically used, and mortality data is one. So the team, this is recently put together, looking at leading causes of death. And so what we can see, this is stratified. If you're unable to see in the back, I'll tell you, it's stratified by race and ethnicity. So on the far left, we start with our Latinx community, Black, Asian, Pacific Islander, Native American, and white. And so what I hope you're able to see is, in each box, it lists the leading causes of death. So the top 6 causes of death for each racial ethnic group is what we have listed here on this slide. And when we look at the red box, that's COVID-19. So in the year 2020, COVID-19 was unfortunately the #1 cause of death for those identifying as Latinx in our county. And followed by heart disease and followed by stroke, heart disease and followed by cancer. When we look at the other racial ethnic groups, COVID-19 was the 3rd, and in one case, the 4th leading cause of death. What I want you to see is the change over a year. So then in 2021, when we look at mortality in our community in the year 2021, it was still the leading cause, the #1 cause of death for those who identify as Latinx. But we also start to see it shift up as a leading cause of death from 4th and 3rd up to 2nd for Asian and 2nd for American Indian, and also the #1 leading cause of death for those who identify as Pacific Islander. So these are disparities, right? We're talking about health disparities, but we're able to see the disparate difference in the leading cause of death across racial ethnic groups. Helps us identify areas that we need to address, right? But also helps us recognize there are differences. And those differences are tied to something that we have to investigate, spend more time figuring out, and then aim to address. So this was put together, the Kaiser Family Foundation, they've got a really great dashboard looking at health equity and social justice and health disparities. And so this is just one slide, one illustration from one chart from their dashboard. And it highlights that people of color fare worse than their white counterparts. There are 27 health indicators that they use for this measure. And when they look at the 27 indicators, they find that for those who identify as Black, they fare worse 70% on 70% of those indicators compared to their white counterparts. So 19, you can see the orange, the number 19 means worse. Blue is no difference, green is better, and then if there are data challenges because of population size and other, then they indicate there as well. But Blacks fare worse than their white counterparts on 70% of those measures. Our American Indian community fares worse on 67% of those measures, and you can see so on and so forth, the different groups, which ones fare worse. Our Native Hawaiian and Pacific Islander group, their population is so small, is a much smaller population, that there are some limitations to that data, and there are some challenges. So I highlight that just to say that just because it doesn't show that they fare worse, that doesn't mean that's accurate given the sampling, the challenge with the sample. We do know that when we looked at mortality on the previous slide for our Pacific Islander group, they experienced COVID mortality disparate, right, disproportionately compared to the rest of our groups. So I had made the comment earlier about health. I always say that their health disparities are persistent and they are pervasive, and they absolutely are. Over the past 100 years, our life expectancy has increased, which is great. We've seen a 30-year increase in life expectancy. Average life expectancy 100 years ago, I giggle because I'm almost at that age, was 48. I was like, 48? Oh my gosh. Average life expectancy. I'm like, I'm about 48. And I was already at average life. No, we need to improve. So we've seen this increase, 30-year increase in our average life expectancy. So an average of about 78 years. There are differences, though, when we stratify by sex, and then when we further stratify by race and ethnicity, or sex and race and ethnicity, we start to see these differences very clearly, and they're glaring. And over time, we've seen the increase in life expectancy, but that increase hasn't benefited everyone. There's not parity in the increase in life expectancy. There are still gaps, and in some cases, the gaps have widened and have not narrowed. So when we look at life expectancy by race, ethnicity, and sex, for example, Black males have the lowest average life expectancy of all groups when we stratify that way. Continuing over time, right? We did see a little bit of narrowing for a period of time where the difference on average for Blacks compared to whites was 8 years, and now it's at 4-year difference. Still, on average, the life expectancy for Blacks is 4 years less than their white counterparts. And that's even far worse when we stratify by sex and race ethnicity. So as much as we've seen improvements, there's no parity in the improvement, right? Everybody's not experiencing the same level of gains in life expectancy. And this is national data, but that holds true when we look at local and state data as well. So I love to use this slide of bringing it back to, well, are we talking about health disparities or are we talking about health inequities? And my argument is the disparity is the enumerated difference, but what you and I are probably most interested in is the inequity. We're not really, the numbers are the numbers. We're interested in what's causing those differences in those numbers, right? We're interested in the differences in the social determinants of health. Why are some communities more or less likely to have access to healthier food options, or more or less likely to have access to adequate housing, adequate transportation, good schools, good after-school programs for their kids to participate in, right? These social factors that contribute to the health outcomes that we see. But more so, why are there differences in those social factors? What is happening that contributes to the differences and that we consider it acceptable to allow those differences to exist and persist? When we're looking at life expectancy, we look at mortality. I wanted to pull up, there's a report written that actually enumerated what they refer to as the tragedy of the health inequity. It's not just increases or differences in mortality related to heart disease, but if we could enumerate the social conditions, how many people die as a result of the social condition, which is of interest to me. So you can see here, it's estimated, and I know this is older data, they haven't updated some of these estimates, but it's estimated that in the year 2000, 75% of all the deaths were tied to social determinants of health, tied to poverty and inequality of income, right? Tied to low levels of education. So when we count them that way, it feels so different, doesn't it, than to count death tied to a heart attack or a heart disease. What if we look back and we're able to identify the social conditions that that person experienced and we're able to tie it directly to education or tie it directly to income inequality or lack of housing? So why should we care about the health inequity? No one wants to be, any of you volunteered at, I'll be vulnerable. You can lump me into a category called vulnerable. No one in this space and nobody who's planning to have children wants vulnerability in their lifetime or in their family experience. Nobody asked to be born vulnerable. No one asked to live in a disadvantaged community, right? No one asked to experience, not only live in a disadvantaged community, but experience disadvantage throughout the entire course of their lifetime. No one asked for that. That's why we should focus on health inequities, because no one asked to be born that way or have that experience as a result of who they are and where they live. But additionally, there's a textbook written by Dr. Thomas Levice. I don't know if any of you have heard of him before, right? It's public health, right? It's like Thomas Levice, right? Seminal in the research around minority health and health disparities, he among many others. But he has a textbook called Minority Health, and in there he talks about the fact that, if you don't care about health disparities because you don't think you're ever going to be impacted, why don't you think about the fact that our social dynamic will change over time, right? The experience of what we all oftentimes deem as the experience of that minority will be the experience of the majority, because we're growing majority-minority community, right? So what we're seeing happening in a group of people that we just don't think is ever going to impact us will absolutely impact us. And what I also like to add to that is, our privilege will not always protect us. Whatever level of privilege each of us experience in this room, whether it's a privilege of occupation, privilege of education, that will not protect you forever. So the experience of disparity and inequity absolutely will impact all of us. So I set the tone earlier with kind of the agenda of what we're going to what I was going to share a little bit about today. And I mentioned the upstream approach. And so here we've landed here at the socio-ecological model is how we refer to it, or what it's called. And in the socio-ecological model, it's kind of split with upstream and downstream. This is, you can Google socioecological model. There's a number of illustrations. This one I love the most, and many of you may have seen this illustration before. This was developed by BARHI, the Bay Area Regional Health Inequities Initiative. They developed this almost 20 years ago at this point. They're a group of Bay Area health departments that got together to address social justice, to advance social justice and health equity. And in that work, they established this model. And actually now, just as a note, the California Department of Public Health has recently signed a contract with BARHI to provide technical assistance to every single local health department in the state around social justice work. And so they just had their task force meeting on Tuesday, where they were outlining their strategy to reaching all of us in the local public health world. But this model, let me see if I'm able to highlight a few things. Maybe not. So I'll describe on the very far right, it says downstream approach. The far right highlights three things on the downstream side: risk factor, disease and injury, and mortality. So hopefully you guys can see those three elements there. That's where we typically spend most of our time. So healthcare practitioners spend their time there, and historically public health has spent all of their time there too. What we do when we spend time here is we're really blaming the individual for their outcome. We're saying, you have a health risk behavior, and if we teach you to do better, you'll do better. And then that will reduce your risk of illness and ultimately reduce your risk of death. That's what we do. We're blaming the victim when we look downstream. And by the way, the downstream side, only if you focus on downstream, there's only 15 to 30% of our risk of death can be addressed on the downstream side. That leaves the 70 to 85% coming from somewhere else. Your risk of death is associated with something else. What is it? It's the upstream side, the policy side, the institutional racism side, discrimination, housing access, education access. Right? That's where, on the far left side, is where we need to be working, and that's what's referred to as the upstream model or the upstream approach. It's targeting the things that we're probably most afraid to try and target, or we feel most challenged with trying to target because our limited power and our limited ability to address those things. If we're not the ones in power or in control, then how do we get an entire school system to do something differently? How do we get an entire school system to think about the ways in which they discipline children that has maybe a disparate impact tied to implicit bias? How do you get people to see that and understand that and have those conversations when they're the ones in power and they're the ones in control? So we back away from that. We just spend time down here on the far right, doing what we know to do, what we've always been trained to do. As a public health practitioner, I won't tell you when I graduate my MPH, but in my MPH program, we talked about the socioecological model, but we were not trained to address upstream approaches. That was not a part of our training. Our training was focused on teaching people to do things differently and putting a lot of the responsibility on our community members and us as individual community members as well, without thinking about the systems in which we all live, work, learn, play, pray. So that is the upstream approach. And that's where we all need to spend our time. That's where we need to focus our efforts and our energy. We already do the downstream stuff good. We know that part. So let's work hard on the things that we don't do so well at, right? So I'll give you an example that's really off-centered from this discussion today. I used to be a roller derby referee. I know. And people are like, what? A roller? It was so much fun until I broke my tailbone. But anyway, and I remember, as a ref, there were positions that I liked to ref. And I remember having one of our lead refs, one of our head refs, he said, you need to ref in a position you're not comfortable in. You need to strengthen that other leg. For me, I was like, what? He's like, you need to skate backwards more. Stop going forward, doing all the things you know to do, dodging the things you're used to dodging and seeing. You need to skate backwards more and be off, right? You have to fall a couple times to figure this out. And I think the same way with regard to the work, the upstream versus the downstream. Downstream, we know how to do so well. How about we flip it and we do something we don't know how to do so well so we can strengthen that muscle a little bit. All right, so the California Department of Public Health, they have a group, a unit called the Office of Health Equity. They're a fantastic group. They've done a lot of great work. They funded a lot of great programs. I see some faces in this room who've been funded by this. And they wrote a report in 2015, and then they revised it in 2020 called The Portrait of Promise. And The Portrait of Promise outlines some of the inequities that we see in the state of California across our communities. And so I just want to highlight a few of them for you here. A higher proportion of Asian and white third graders are reading at above or near standing compared with African Americans and Latinos. Latino or non-white populations are more likely to live in areas with a high burden of pollution. Now, this is data for our state, for the state of California. About 40% of African American women reported experiencing racial discrimination compared with 8% of white women. Teenage arrests for marijuana possession disproportionately affect boys and African Americans. And by the way, when they looked at this data, they also have self-report across race, ethnicity, and sex asking about use of marijuana. So there is no disproportionate self-report experience of use. So when you ask a teenage boy, do you use marijuana, yes or no, and they're looking at those proportions, they see they're similar across racial ethnic groups. But then the enforcement is disproportionate. Just to highlight that for you. Access to health insurance or usual source of care is lower among racial ethnic groups with serious psychological distress. Non-white male students non-white male students are underrepresented in California higher education. So what does moving upstream look like? And I highlight just 3 ways in which we're doing this work in our county, in our local health department, in partnership with many of you in this space. And so I'm just going to highlight 3. One is addressing root causes, so having these important conversations around racism, discrimination, and bias. The second is doing a lot of work in power building and power sharing. And then the third is developing an equity and justice priority setting for our county. So first, the addressing root causes. You would assume that today, at this point in time today, the statement that racism is a health issue is not foreign to most of us in this room, right? We share the same space and we all agree. But do you think that's the case when you walk out of this space? That that's an agreeable statement? Right, when you have conversations with people like, oh, racism is a public health issue, but more than that, it's a health issue. We're still trying to convince people that racism is a health issue. Even beyond all the declarations that have been made, which I'll talk briefly about in just a moment, but we're still trying to convince people, even post all of the research that's been done. In the 90s, there was a heavy push towards research around the impact of racism and discrimination on health. A lot of seminal articles were written addressing that. And then there were surveys. Then the question becomes, well, do you have data to support that? It's one thing to make the argument, but do you have data today? First it was, do you have data? Yeah, we have data. We've got historical. Well, but do you have data today? Because we look so different today than we have in the past. Okay, so you have data, right? We've got the discrimination scale created by David R. Williams at Harvard that measures discrimination, the experience of discrimination, and it's strongly correlated with health outcomes. Right. So we have a number of those tools, and there's still questions about whether or not racism, discrimination, or bias impacts our health. Really, we're still asking that question. And I pose it that way, knowing that you guys agree with me. I'm in a room full of friends, I'm in a room full of believers in this work, but we're still pushing because we have to. We still have to make it clear. We're still pushing that work in local government. In public health, we all agree. But we are not the only local governmental entity in the county, right? We work in partnership with probation. We work in partnership with the sheriff's office. We work in partnership with social services and behavioral health. Right? Our aim is to make sure that we all, as local government, have the same understanding, not just that public health has one understanding. So as a step in the right direction, we, as many other health jurisdictions, states, school districts, community colleges, universities made declarations. Do you guys remember that? It was like a hot topic. Every day you look at your phone and you're like, oh, another place made a declaration. Another place made a declaration. The American Public Health Association actually keeps track of that. They have a record. They have a great map, and you can pull up and see who's made a declaration, either recent or at all. At this point in time, there are over 260 counties, states, cities, townships that have made formal declarations as racism as a public health crisis. We did no different. April 4th, 2020, our Board of Supervisors made a proclamation that racism is a public health crisis in our county. And actually the way it reads is that racism and inequity are public health crises. And then on that declaration, if you've had an opportunity to look at it, if not, I will gladly send it to you. They list tasks and responsibilities, what we are charged with doing, and what county departments are charged with doing. And one component was charged with working directly with public health, with local public health, on addressing racism as a public health crisis. So 2.5 years in, a lot of work still has to be done in this area. There's been lots of great work that's kind of set the foundation for the conversation, but the conversation hasn't gotten any easier just because the declaration's been made. We still struggle. We still struggle with some departments, with groups that say, is it really racism though? I think it's more like income, isn't it? I hear that a lot. I'm sure many of you in the spaces have heard that a lot. Or is it racism, or is it just perception of racism? Hear that quite a bit as well. So the other piece of this is doing work not only on racism, but also on implicit bias, to get folks to understand that there's something called implicit bias. We all have our own implicit biases, and that influences the way we respond to people. It influences who we want to engage with, who we want to listen to, and what work we want to do. And it's easy not to think about it. It's easy to assume, no, I would never discriminate. I would never behave in a way that is biased in any way. I think of that myself. I'm like, I'm a woman of color. I'm not going to be biased towards anybody. No, we all have our biases. We've actually contracted with a number of groups to offer require for our department implicit bias training to our staff, because it's that important to us to incorporate it in the education and the workforce development for our department. So when I talk about implicit bias, and I've done a couple little things on implicit bias, I remind people that it's the subtleties that you don't even think about. So I give the example, and I'm embarrassed to give it, but I'll give the example of this was last May too, so not long ago, me being at the airport, and I'm waiting for my flight, and it was delayed, and you hear the young lady on the overhead say, the flight will get ready to board as soon as the flight attendants arrive. And so I look around to see when the flight attendants are. Do I see them coming? And what I realized, I was like, oh, I'm picturing women. That was my first thought, was to picture female flight attendants walking by. I was like, oh, that's implicit bias. That's my internal bias, right? Because I've been socially conditioned to picture that. And I haven't broken that. I have charge of that. I can correct that myself, and I hadn't. And then we get on the plane, and then they say, so your captain's going to address you in just a moment. And my first picture was what? A man as the captain. Guess what? Captain was a female. And she announced that this was one of the first flights for her to have an all-female crew as well. So all the flight attendants were indeed female by chance, but the pilot and the co-pilot were also female. But I thought to myself, just on that flight, I was like, dang, like I'm riddled with bias, and I never would have thought. My first instinct is, oh, no, I see through my biases. I get past them all the time. But even that small subtlety. So then think about a bias that you have about a racial ethnic group, a stereotype that you have about a particular ethnicity or a particular sex or orientation or gender identity. That influences your interest in working to support whatever cause is important to that community. Are you going to go the extra mile and put forth the extra effort and the extra work to provide that community what they need, given your bias. That's what we're dealing with upstream, structural inequities, right? The assumption that certain groups are a particular way, or certain groups have done this to themselves, or, well, that's a result of this within that particular group. Absolutely not. Those are the tough but important conversations to have, and we started having those across the county. All right, so another slide, just kind of highlighting unconscious bias. I highly recommend, if you have not taken the implicit association test, I see a couple nods, so some of you may have taken that, take it. There are 15 of them, by the way, covering racial ethnic bias, religious bias, you name it. A whole host of them. So take every single one. Take a break in between, take every single one. They just take a couple minutes. You will be very surprised at the level of bias you have. According to the test, based on your experiences, remember, you live the experience, right? You have a lived experience. You've been socially conditioned to feel, think, and believe a particular way. And with the implicit association test, the data that's been collected from the use of this test in the United States finds that overwhelmingly there is a negative implicit association with people of color. Overwhelmingly, when you look at all of the different types of implicit associations and negative associations, they find that overwhelmingly those associations exist tied to people of color. And they find that implicit association even exists among people of color towards people of color. Take it if you haven't taken it. So implicit bias is an area that's important to address, and all of that falls under kind of looking at and addressing the root causes, with racism and discrimination and bias being a root cause. And then sharing power and building power. That is so key, power building. I mentioned earlier that when you look upstream, these are these large institutions, and we might often feel like, well, how am I supposed to do anything? I'm not invited into their space, and when I am in their space, I'm ignored, I'm disregarded. How do I get in? How do I get heard? The power is so important, power building and power sharing. So we are very fortunate to be working with groups like the Prevention Institute or Human Impact Partners, Race Forward, organizations like GARE, the Government Alliance on Racial Equity, and Southern California Public Health Alliance. A lot of these groups are doing a lot of work in this space focused on power building, power sharing, and helping local health agencies and community groups build power and share power across. Just a few examples of some of the power building and power sharing. This is from the Public Health Alliance of Southern California, and they actually highlight us here in Riverside in their book outlining some of the power building and power sharing work that's happening across the state, or Southern California in particular. They highlight the work that's been done in Riverside County in partnership with Starting Over. You've heard of that organization before. So this organization focuses on supporting the formerly incarcerated. And so there's a lot of work and partnership between our health department and other county departments with Starting Over. The Alliance has helped us write a power building starter kit so that we can push this out to our community partners, helping to outline how you can fight for power, how you share power, right? It's about, if we as a health department have power, right? There's power that we have inherent in who we are, but we shouldn't always use that power. Instead, we should lend that power to others and leverage our power to other groups, because they can do a better job at this work than we can do as a health agency. And so power sharing and the starter kit is really helping us to see clearly how are the ways in which we can share and build power up in other groups that we didn't even realize we were neglecting to do. It's easy for us to think, oh, we're doing it right. We don't need anybody to come teach us and tell us anything. No, we're lifelong learners. We need to constantly learn about what we're doing and how we can do it better every single time we do the work. Also offering training and workshops to all of our staff, but also to our community partners around power building as well. We have some resources, financial resources, to be able to pay for that training. So let's cover it. Let's make sure that our community gets access to those resources, but also let's make sure that all of our employees are provided those resources as well so they can continue the message. So here's a good example of power sharing through what I call knowledge exchange. On the left, I'll focus more so on what's on the left. So this is our vaccine priority measure. What we had during COVID, we have a vaccine equity task force. A lot of counties had vaccine equity task force to help them talk about which communities were at greater risk of COVID, help the community-based organizations and provide them with a platform for sharing and asking for resources. And so in our vaccine equity task force, the conversation was geared around, well, how do, CBOs, community and faith-based organizations, they're going out, they're canvassing the neighborhoods, they're talking about vaccination, they're pointing people in the right direction, but how do they know which communities they need to target? How do they know whether the neighborhood they're currently targeting needs that level? Maybe they're already saturated with vaccination, right? Maybe there are some communities where no one's going knocking on the doors, and those are the same communities where vaccination rates are low. So power sharing. Our epidemiology team put together a map and created an indices that said, okay, these are the hot spots in the county where COVID cases are high, and then these are the areas where vaccination is low, and here's the areas where COVID cases are high and vaccination is low. There's your target. And then the community and faith-based organizations were able to take that data and run with it. And then we're able to monitor it over time to see the impacts of that work. That's sharing, right? We have a resource, they have a resource. We're both leveraging our resources together for the common goal of getting people vaccinated so we can prevent the spread of COVID. Another example, power sharing for suicide prevention. We can't do this work on our own. We rely heavily on our partners with resilience and suicide prevention. So here, a couple examples. You Matter Collaborative. We participate. We are not the lead of the collaborative. We're a participant. We're invited. You're invited. We're all sitting at the same table, but somebody else is leading. Historically, public health has been at the lead of a lot of the work that's happened. And, for good or bad, that's just how it's been structured. Public health has had the financial means, the staffing resources to be able to do that. But now, through a lot of the work that we're doing and the learning that's going on, it's like, we might have a resource to help be a convener and get people started. And then we are a member. We are an attendee. We are a participant not unlike anybody else in the same space. And allowing that power sharing to happen. Another one I'll mention very briefly, but you have a seminal subject matter expert in this space today who's going to present in just a little bit on the ROTA program, but I'll highlight just briefly some work that's happening, power sharing across departments, county departments around overdose prevention. We are very fortunate now. We had funds. We received a CDC grant to develop a Riverside overdose data to action is the name of our program, the ROTA program. Through those funds, we've been able to develop a fantastic dashboard, an overdose dashboard, so you're able to see data as up to date as we can, make it available to the community, but data on overdoses that are happening on our county, so you're able to see that in the dashboard. We also have an individual from the sheriff's office who's co-located, who actually is seated and works in the local health department on this work. So that means we're more timely able to communicate and we're able to share data and information really quickly, establish plans, some next steps, and then they're working on so much great work around overdose prevention as a result. I want to highlight one other thing here. There's a lot on the slide, I know, so I'm going to highlight the second to the last bullet. Inland Empire harm reduction, working with emergency medical services on policies and programs around Narcan, naloxone leave behind program, right? What does that look like? How do we build it? And how do we make sure that we're keeping track of the success that we have as a result of the work? All right, and then the last thing I'll highlight as a third upstream area is our equity and justice priorities. So we've been able to work with, I mentioned earlier, a group by the name of the Public Health Alliance of Southern California. And they've helped us really look at ourselves and look at what priorities we need to have in Riverside County that are all upstream. And so I'll highlight for you, there are 5 of them. The first one is building an internal equity infrastructure, right? So measuring that landscape. And there are tools for that. I mentioned BAR-HI earlier, showing you their model, the BAR-HI model, the upstream and downstream. BAR-HI also has an organizational assessment. It's a tool that you can use to assess your readiness. Where are you around the work around racial equity and social justice? Are you ready for the work? Do you have the capacity in your organization? Race Forward, on the far right, I have an illustration from Race Forward. They also have an assessment tool. The state Office of Health Equity, they've put together an assessment tool. There are a number of resources that then help us say, let's measure ourselves, measure our internal capacity. And a number of these resources are not just for your leadership to measure, but you can send it out to your employees of your team and get their individualized opinion about where you are as an organization, how they feel you are equipped to do this level of work. Right? So there's a lot that has to happen internal. We did a lot of internal work years ago, and now we're taking a step back, and times look different than 10, 15 years ago. Very different. So we have to start over with some of this work and build on some of our previous work, building a lot of internal capacity. We have a health equity program now, which we did not have 10, 15 years ago. So now what is that program going to look like in 5 years? Vision setting for the work that our health equity program is doing and our health equity outreach teams. If you didn't know, we have health equity outreach teams, a team for every single supervisorial district in our county, so 5. We have 5 supervisor districts. We have 5 health equity outreach teams also. And those teams have representation from public health, from animal services, from housing and workforce solutions, behavioral health, right? We're environmental health. We're working with a number of groups, first 5, like all the names just keep coming to me as I'm thinking about all of the folks that and it's growing. The numbers of organizations that are participating with our health equity outreach teams continue to grow. So just an example of some of the capacity, the infrastructure and the building that has to happen. Dashboards, our team is working on a health equity dashboard. It's going to be so exciting to see, something that you all of our community members and partners can use and look at and provide input on. And so stay tuned because that is coming. I highlight on the very bottom block is the Kaiser Family Foundation's dashboard. They have a number of elements in their dashboard. And in their dashboard, they ask questions about community members and then they post, the percentage response. And this one in particular, they asked about experience of discrimination and the disparate or the difference in the perceptions among those who identify as white compared to those who identify as Black. We're also, we now have a membership for GARE, so the Government Alliance on Race and Equity, a lot of great tools offered by GARE, and I highlight one of them because it's the second bullet, which is looking at our procurement and contract. That is so hard. Right? Someone who receives grants from what we've learned over the past few years, we've known, right? But we are so set in the work that we do all the time that, this is process. This is a county process. This is the way we do it. It's county purchasing. It's downtown. It's this. And what we've learned is that we cannot support the growth of our community if we do not look at our practices and make them equitable. Who are we granting dollars out to? Are we making the process easy for them or difficult? We push out small mom and pops by having a process that's extremely challenging. I see a lot of head nodding because I'm sure you've experienced it firsthand, that when we make the process so difficult, we are, in essence, excluding you. Unintentionally, but we're excluding you. And when we do that, then are we reaching equity? We're not. We then have overrepresentation of some groups, underrepresentation of other groups with our funding, with who we've provided resources to. So we are absolutely looking, and there are a number of resources that we've identified to help us work on our procurement and contracting processes to better support the communities that are doing the work. Also focusing on providing technical assistance and uplifting support to our community partners as well. It's easy for us to grant you money and say, okay, you need to report back and evaluate. And they're like, well, I've never done that. Are you going to help me? No. You have to figure it out. And by the way, you know, for those of us that do this work in the space, we know how heavy of a lift evaluation is. You hire people to do that. Like the academicians in this room are like, yeah, I'm a contractor for that, right? Like you get grants and you evaluate that work. It's hard to do, but we have to do the work, but we have to fund it too. And then we expect a small community-based group to have a heavy lifted evaluation, formal evaluation plan, report the data to us timely and in the way in which we want to see it. So I won't keep beating that one, but you know where I'm going. Well, it's our team, our health equity program, the leadership within our health equity program, which our chief is here today. She's going to be presenting next. Wendy Hetherington is in the back. So overseeing that entire unit, and this is a priority for her and a priority for her group, for her teams to work on, and a priority for all of us in our department. One case study I want to share is our health equity outreach teams using Healthy Places Index, which I talked about earlier and highlighted for you, using that data, making sure the community partners that we work with also have access to that data so they can do the work. So this is a photo of one of the groups that we work with very closely, TODEC, and they go out in the community. They do a lot of work with our migrant farm working community. We would not have been able to reach our migrant farm working community and vaccinate at the level that we did, provide resources, education, if it wasn't for organizations like TODEC. Second, we're building a strong, diverse, and equitable workforce and culture. So to do that, we're looking at our trainings, right? How do we train on equity and justice? We've offered trainings to our staff. We continue to offer trainings to our staff around equity and justice. Implicit bias, I talked a little bit about earlier. We're working with our county, so downtown executive office, around hiring practices. Right, I heard that. The hiring. I'm like, I heard it. I agree. We all agree with you. And it's even earlier than hiring. It's not about who we hired because they were on the list. How do people get on the hiring list in the first place? How do they know to apply for the position? How are the institutions, the colleges, the universities, the programs preparing them for these types of positions and preparing them to apply, helping them to apply, marketing the positions? All of that is a part of our discussion around equity, because we continue to have the same folks apply, which tells us there's something broken upstream around our recruitment and our retention practices. And we want a workforce. To have an equitable workforce, the workforce has to be representative of the community in which they serve. And we're not there yet. Right? We have a lot of work to do to get there. I mentioned education and training, just highlighted. We have training that's been happening on trauma, right? So trauma-informed care, trauma-informed leadership. There's a lot of discussion around trauma, and I'll say it the way Wendy says it best, actually, is that, you know, we're coming off of COVID, right? There's still COVID in our community, so I will not say that COVID is gone or it's gone and away and it's over. No, by no means. But we have staff that are back in work. They're back in person doing work, and they have not been able to unpack, right? Unpack the trauma that they've experienced as a result of COVID and everything that happened around COVID, right? So those things have not really been unpackaged within our workforce. So we then have a workforce that is providing service to a trauma-impacted community, and the employee who's providing the service is also impacted by the same, if not greater, trauma as well. And we haven't unbaggaged that. And then we have leaders that are supervising and managing staff that have experienced trauma, who are providing care to community members who have experienced trauma. It just continues to trickle down. Supporting authentic community partnerships. A lot of work around making sure that we're funding community groups at the rate at which we should be funding them so that they can continue doing the work, but also continue engaging in conversation. We had our vaccine equity committee, our vaccine equity task force during COVID, but as things have wind down, we may have transitioned away from the vaccine equity task force, but our communication and collaboration has not gone away, and that has not wound down. And so as a result, we have lots of other ways in which we continue to engage our community partners and cross-collaborate and share. So I have a number of them listed here, just a few. Those aren't all of them, but these are a few that our team participates in actively, that either we facilitate as the local health department or we are sitting on and participating in, and it's facilitated by someone else, by another organization. And then last two, advance our equitable data practices. I talked earlier about dashboarding. We have a great team, a great epidemiology team that is the heart of the work, the equity work that is happening in the department, started in our epidemiology program. And so you've got people there that say, look, there are a number of ways in which we can make sure that not only the data we're capturing reflects the community, but we're also reporting it out and pushing it out in a way that better supports the community. So as one example, I know Wendy and her team, they looked at how we were reporting data on Native Hawaiian and Pacific Islander. And it used to be that you would see Asian Pacific Islander as one group, right? Which typically that's how the data is because population's small. We always make that excuse. It's easier. I will say that as an epidemiologist. Aggregating data is so much easier because then you've got enough sample size, so you've got more statistical power. The problem, though, is that we're lumping groups that are very diverse together. So those who identify as Asian are not similar to those who identify as Native Hawaiian or Pacific Islander. They're very disparate or different groups. So how do we do a better job of making sure we highlight those differences if we don't separate and parse out that data? And that came from community saying, you got to parse the data out for us. Come on. Like, we can't target, we can't aim, we can't do the work without really knowing the who and the where. And so as a result, our team makes the effort to always parse that data out whenever they can. So it's those types of, that collaboration, right? We'll just continue doing status quo because that's what we've been doing. But unless we're engaging with each other and having the right conversations, then we don't change. And lastly, expanding this work countywide and cross-governmental. So earlier, a few slides ago, if you remember, I highlighted our Board of Supervisors resolution, our racism and inequity as a public health crisis. As a result of that, the county, so our executive office, our county CEO, has hired a diversity, equity, and inclusion officer. And that officer is responsible for bringing together all of the county department heads. So you have the public health director, you've got the social services director, the behavioral health director, and they're all together in one space talking about health equity, social justice, racism, discrimination, and how to move this county forward. We also, as a result of this, have brought those same folks together to develop our county health equity strategic plan, which should be finished by mid to late summer. And that is coming from community. So there are two elements to that plan. Community advisory groups have fed into that plan, but also the department heads. And when I say department heads, I mean, I named a few. That includes the undersheriff. Right? The sheriff is sitting at the table. The undersheriff is sitting at the table representing the sheriff's department, providing input to our county plan. So I thank you very much for your time. I think I went over a couple minutes. I'm so sorry. But I wanted to just thank all of our partners. You may see your logo up here, your organization up here, UCR is up here. But when I talk about collaboration and partners, I'm not kidding. And this is put together by our health equity program team led by Wendy. So they're the ones who remind me every day of, no, don't forget, this group is also a partner, has a seat at the table or gives us a seat at their table. So I just wanted to highlight a number of the organizations and our tribal partners as well. That we couldn't do any of this work in the equity space to advance social justice without all of you in this space. So thank you very much. All right, any questions for me before we transition to our next speaker, who is fantastic, by the way? Yes. Oh, absolutely. Great question. So the question was, how do we see homelessness and mental illness fitting into our equity plan? We have representation from the organizations who do that work. That's how it fits into our equity plan. So you have Housing and Workforce, who's doing a lot of work in the space for the unhoused. so those who are unhoused, but then also our behavioral health. We do a lot of work with behavioral health in a number of programs. I mentioned our overdose program earlier, our suicide prevention resilience program, but in the equity work that we do, they're a member of our district equity team. So our health equity outreach teams, sometimes we call them district teams, they have representation there, and they are participating in our committee meetings to develop our strategic plan. So the input from all of those partners, you make a good point, you ask a great question. Is that input, are we capturing that input? And we absolutely are, to develop our plan. Yeah. And that also means that plan is not final until we push it out to community. Because we've got a number of community partners that I'm sure you're thinking, well, what's in the plan? What are you guys going to be working on? And did you get input from community partners? And we absolutely have been getting input from our community partners also.
Power building, and I noticed all the community partners, but I still sense as a community member the disconnect. So how do you guys and the partners reach out to the community where we're actually having a share in that power if we're not at the table?
That's a great question. There's a couple ways, and when I say a couple ways, it doesn't mean they're happening just yet. We also have, as you saw, there's a lot of things that are in the plan, right? And there are a lot of things that are recommended to do, like holding listening sessions is a good example of that, holding town halls for community members. Those are things that we're exploring, how best to make sure that we're getting input from all community members and across sections and sectors of community as well. Because some parts of our community do a really great job of making sure that the voices are being heard, and there are some parts of our community where we still struggle at doing that. So yeah, having engagement from our CBOs and our FBO partners, but they also tell us, hey, we're not getting the input, or you're not getting the input the way we would like to see it. So here's some recommendations, and those recommendations are what we move forward in our formal plan. Yeah. So thank you for bringing that up. So I'll always keep that in mind. It's like, wait, how do we make sure that everybody has a voice and that everybody's being heard? Yeah, absolutely. That's a good one. How do we push it to schools, get our schools more involved? We have school partners, but I want to think about how to get schools engaged around the equity discussions, not just equity of these specific topics that we engage them around, but equity overall. Here we go. Thank you. Thank you for that.
Okay, so how would a grassroots organization within the community who have the research, who have done the questionnaires, how would they be able to get that information to you if they're not at the table?
That's a good question. So we use our coalition, we use our Equity and Justice Collaborative, but if folks aren't at the table, then we rely on those folks to come to us. And we also we have staff that participate in a lot of community meetings too, to identify new partners and identify new spaces where we're not at. But you mentioning that here is a good example of the fact that we're not everywhere. All we can do is be where we're invited to be and push where we can push to enter. So if there are places and spaces that we're supposed to be that you don't hear us and see us, or we don't see you, because if you don't see us, that means we may not see you either, then let us know. Reach out to us so that we can include you and that you can invite us so we can participate as well. Awesome. Thank you. Because as much, there are places to be, but we're not everywhere, and we want to be everywhere. We definitely do, and sometimes it requires us to be invited. We find out about events that we're not invited to, and we don't hesitate to say, hey, we're just going to kind of step on in and invite ourselves. But I appreciate you reaching out to share, because we would love to participate with you.
Dr. Penny, hello.
Hello.
Okay. Thank you. I feel like I am in a meeting that I should have been 10, almost 20 years ago. Thank you for sharing that the conversation has changed, that public health, Riverside specifically, looking at the community for information, for direction on how to change what has been going on for years. So I just want to thank you, and I'm so excited that you're leading the charge. Michelle's leading the charge. Thank you so much, and you know that we're here. Healthy Heritage is here to support you.
Thank you, Phyllis. Thank you.
Thank you. Can we give Dr. Penny another? Thank you so much. Thank you so much. Now we have the opportunity to have one of our CAB members. She's actually a new CAB member to our Health Disparities Center, and we're excited to have her come and do a workshop for us. So I'd like to invite Wendy Hetherington. Where is she at? Okay. Hi, Wendy. Come down. Wendy is the Chief Epidemiologist for the County of Riverside Department of Public Health and is responsible for leading the Epidemiology Program Evaluation Branch. She manages a team of epidemiologists and research specialists who analyze data, prepare reports and presentations, use statistics and GIS guide program and policy development, and a team of program coordinators and health education assistants who use the data to collaborate with community partners and members to improve health. I think that's very important. Not only do they collect the data, but they go out and they give it to the people that are out in the community who are reaching out to you. So if you see people, I think this is really important for us to talk about. When people approach you from Public Health Department, from UCR, and ask you to participate, to collaborate, to partner with us on research, collecting information, please join us in doing that. Let your voices be heard. I think that's the biggest challenge that we have going out. You know, community says we want to partner, but then when we come out and ask, there's, well, I don't think so. I'm not interested in serving on this focus group or doing the survey. We really need to partner with you in order to advance, go upstream, right? Make some changes, make some real impact. So I'd like to invite Wendy. I'm so excited because, like I said, she's a new CAB member of ours, and CAB stands for Community Advisory Board. And we asked who would be willing to do a workshop, and she graciously agreed. She graciously agreed with no hesitation, so I really appreciate you, Wendy.
Thank you. I'm going to be my full authentic self here and let you know that this is only my third in-person presentation since COVID, and so I'm a bit rusty. And thank you, Dr. Penny. You teed up a lot of what I'm going to say very well, but following Dr. Penny is making me a little bit more nervous because she's such a great presenter. And I, again, being authentic, I have notes. So I will be looking down at my notes frequently just to make sure I hit all the main points I want to hit. And do I just press this red point here or point? Okay, that one. Okay. Okay. As I mentioned, this is my first time, or only third time since COVID. I'm going to talk about reducing stigma and increasing harm reduction to address the overdose epidemic. And really tied into this is a discussion about how we formed our Riverside Overdose Data to Action Program, as well as using data to change the narrative, the common narrative that's out there about overdoses. Oftentimes people talk about the opioid epidemic, and I always say the overdose epidemic because it's a lot more than just opioids. So these are some examples of some headlines you may see in the newspapers or other online news places. And you see, like, most of the attention involves fentanyl and its criminality, such as, there's a massive arrest of lots of drugs coming in over the border. And as Gabor Mate says in his book, In the Realm of Hungry Ghosts, about the 4 pillars of social policy towards addiction, the first is prevention, the second is harm reduction, the third is treatment, and the fourth is law enforcement. And his quote is, "In practice, only the fourth and least helpful of these so-called pillars receives unquestioned and generous financial support from governments." And the war on drugs is, in fact, a war on people who use drugs, and most often those that are Black, brown, unhoused, or otherwise under-resourced. Okay, and before I get started, I'm going to be talking about death data, and what I like to start these presentations with is to remind that every number is someone's mother, someone's brother, someone's relative, coworker, colleagues, friend, neighbor, and just remember, as these aren't just numbers. This is a subject I'm very passionate about, and it's not just numbers, but when you're looking at charts and graphs, it gets very clinical, and just remember, every number is a face. So as you all know, overdose deaths have been increasing for more than 15 years. In terms of Riverside County, about 76% of our overdoses are in people who are identified as male, and 24% are female. There was a big jump in 2020, mostly due to fentanyl and probably due to impact of the COVID-19 pandemic. Oh, on the previous graph, that 2022 data is still preliminary. That's provisional. It takes about 6 months post-year for maybe us to finalize the data. So we are on track to, in 2001, we had 806 overdose deaths in Riverside County. And we'll probably have similar or a little bit higher in 2022 by the end of the time the data ends. The Riverside Overdose Data Action Program was funded by the Centers for Disease Control, and one of the requirements was that you had to have at least 395 overdose deaths in 2017 and a certain number of population. I think it was 300,000 population. So of course, Riverside County met the population easy. What I always like to point out to people is that if they had used 2016 data as the qualifying, we would not have qualified. And in 2021, we had 806 overdose deaths, and 2022, probably similar, a little bit higher. And then what I also like to point out is that most of our overdose deaths are due to methamphetamine, and that has always been a case. Meth has always been the drug of choice in our communities, and now with fentanyl on the scene, I think it's increasing a lot of the deaths that we are seeing. So as I mentioned, there's been a large increase in fentanyl overdose. That's what all the headlines are saying. Fentanyl overdoses have, 80-fold increase since 2011. 2011 is actually when we first saw through our toxicology reports and on death certificate data that fentanyl arrived in Riverside County. Starting in 2015, fentanyl overdose deaths doubled every year. And then there was, like I mentioned, the big jump in 2020. And again, methamphetamine overdose deaths have been increasing. We had a relatively stable number of overdose deaths due to methamphetamine, and then in 2009, methamphetamine overdoses started to increase slowly, and then now we are seeing a lot of methamphetamine and fentanyl deaths, and that again increased in 2020. Okay, I love this chart, and I'm going to explain it, but it just really shows why we can't really address the fentanyl problem unless we also address methamphetamine. I'm actually going to put on my reading glasses to see this. So 2007 to about 2013, 14, we experienced about 200 overdoses due to drugs other than fentanyl or methamphetamine. And then you may notice that's the yellow bar. And then starting in 2009, I mentioned methamphetamine went up. And so methamphetamine, the gray bar, so that's methamphetamine without fentanyl. And then 2011, as I mentioned, fentanyl overdoses started to increase. And then if you look, there's the orange is methamphetamine with fentanyl, methamphetamine with fentanyl. And now you could see that about 80% of our overdoses are due to either methamphetamine or fentanyl and nothing else. I mean, there's other drugs involved, but there's overdoses without fentanyl and without methamphetamine account for only about 20% of our overdose deaths. When we read news about overdoses or fentanyl overdoses, there's a lot of big headlines about overdose or a group of high school children or involved high school children. But what I really like to point out is really 3 out of 4 of our overdoses are in people who are 35 years or older. Oftentimes I hear that, it's first-time users that are inadvertently taking fentanyl and they don't know it, and that's a myth. And that's a narrative I like to change because, people who are 35 years and older aren't typically first-time users. They're not people who they're people who have struggled with trauma and have struggled with addiction for probably or sometimes many years. And then I also like to point out that all the older age groups are increasing in terms of the rates of overdose deaths, while our youngest age group that we look at, 15 to 24, is actually decreasing. And again, to something that Dr. Penny said, when we look at rates, you really need to have a lot of good numbers well, good numbers is bad to say about deaths, but have a high number to do stable rates. And so on this chart, I only have Black, African American, Latinx, and white, but we do keep track of all the other race ethnicities, and we do disaggregate internally. But when we look at rates, we need those higher numbers to have stable rates. But what is interesting with this chart is, for most of the historical trends, people who identify as white have had higher rates of overdose deaths, and that's probably why we received funding under the former president's administration. But in 2020 or 2019, overdose deaths, the rate has increased in Black African American, although the numbers are relatively low compared to people who identify as white or Latinx. The rate has been increasing. And also what's not demonstrated on this graph is in 2022, all our race ethnicity groups, their numbers of overdose deaths have started to decrease or stable, with the exception of Latinx Hispanic community, where the rate hasn't really changed all that much, but their numbers aren't decreasing, they're increasing. And so there's something going on in that community. And so now we've started partnering with some community-based organizations that work with that community to help with messaging, harm reduction, anything to help that community out. And then this is really my platform, and thank you for your question about the unhoused population, because to me, I see people who are experiencing homelessness as our neighbors. They're just our neighbors without houses, because of our funding for the RODA program, Riverside Overdose Data Action, we were able to get better data. So starting in 2019, we were able to look at if the person was experiencing homelessness at the time of death. And in 2019, we had 50 overdose deaths, 51 or so overdose deaths in that population. In 2022, what we're seeing is that again, this is preliminary data. It's not, we have probably about till June until we know for sure, but we're probably going to have at least 200 deaths in that population, and that's 1 out of 4. 25% of our overdose deaths are in the unhoused population, and I don't see the news articles screaming that. I don't see the attention, and that's why I say we really need to use data to help shape the narrative and look at that. And in our homeless homeless population, you know, we don't really have a good count or representative of what the actual population of this. The last point in time count for Riverside County was 3,316 people who were experiencing homelessness at that point in time. I know that's a severe underrepresentation, but even if you multiply that by 10,000 or 10 and the rates are really high in that population. And 86% of the people who are experiencing homelessness at the time of their overdose death are identified as male, but we are noticing in 2022 data that the female population in that group is increasing, and that's concerning to me as well. So starting in April 2022, California death registrations now include a homeless or unhoused indicator. So the very first time we're able to see for more than just overdoses now what the unhoused population is what are their causes of death. And this is only, so from April through December when this data was pulled, so it's a very limited sample and not a complete year represent, but of the 105 deaths registered between this time, 70% were unsheltered or 79% were unsheltered at the time of their death, and 18% were sheltered. And then 50% of those deaths were due to overdose. And then when we look at leading causes of death, you can see drug overdose is the leading cause of death in the unhoused population. I like to point out number 3, which is the motor vehicle pedestrian fatalities. In this very small sample of 105 deaths, there were 7 deaths in that category. But when you think Riverside County as a whole experiences about 50 to 55 pedestrian motor vehicle fatalities a year, that's really concerning to me, and that's something else that we could focus and put our efforts towards. So all this data demonstrated a need to enhance surveillance of overdose morbidity and mortality in Riverside County, and then use that data to guide overdose prevention efforts and create a more responsive and collaborative prevention efforts to address the upstream causes of substance use disorders and overdoses. So the Riverside Overdose Data to Action program was established in 2019 through a 4-year grant from the Centers for Disease Control and Prevention, and it's housed within Riverside County Public Health. And at the time, the eligible recipients were 50 states, 8 territories, and 20 local health jurisdictions, and those were the jurisdictions I mentioned where you had to have that 395 overdose deaths and 300,000 population, and Riverside County, unfortunately, qualified. So there's 2 separate but equal parts of our program. There's the surveillance aspect, which is the data, and then the action part, which is our prevention programs. And in our surveillance program, we produce monthly surveillance reports. We have our overdose data dashboard that Dr. Penny mentioned. We've started an overdose outbreak response where we have combined data. We get suspected overdose deaths from the coroners. We get data from our EMS partners, and we get data from our public health. We have a hospital emergency department surveillance system where we get near real-time data, and combining those, we're able to identify when there's an increase in overdose deaths to help then share that information out with the community so we could prevent future overdoses. And some of our prevention programs are, we have an overdose fatality review team where once a month we have partners from the Sheriff's Department, probation, DPSS, public health, obviously, Inland Empire harm reduction, Inland Empire health plan, and others that participate. And we review a selection of 3 to 4 deaths, usually around a theme. Sometimes they're, youth overdoses. Sometimes they're people who are experiencing homelessness, just on a theme. And then what we do is we share information that is available in our records. This is all de-identified except for the people who are sharing information about the decedent. And then we talk about where in this person's life could there have been a prevention activity or something that would have been done. Unfortunately, we see a lot of people who experience abuse or neglect as a child, people who have been justice involved, people who there's aspects, and it's a system-wide and a systemic process that we have to do to address overdoses. And so just we collate all the recommendations, and then we have a tracker where we keep track of where we are in getting these recommendations implemented, working with our community partners to do that. We also have great linkages to care programs where we work with our public health nursing program, as well as Starting Over and other CBOs, where we link people who need behavioral health services or other medical health services to their appropriate place to help them do there. We have academic detailing program where we work with Inland Empire Health Plan, where we work on training pharmacists and doctors on safe opioid prescribing and prescribing Narcan. We have youth overdose prevention trainings that we work with our school districts and other CBOs. And then again, we also have harm reduction and naloxone trainings that we work in partnership with Inland Empire Harm Reduction. So this is a quote from one of our Riverside Overdose Data to Action community partners. We are trying to find our way through a complex problem that not any one agency or individual can address by ourselves. To go upstream, though, requires collaboration of multiple sectors and cannot be accomplished by one sector alone. We conducted interviews with our steering committee members about halfway through our grant funding, and one of them perfectly summed up our collaborative that we are trying to find our way through a complex problem that not any one agency or individual can address by ourselves. Ultimately, it takes a village to do this work. We need to increase partnerships across organizations. Public health cannot do this alone, so we can improve access to services regardless of use, advocate for harm reduction, safe consumption sites, and ultimately reduce interaction with law enforcement. The role of local public health department is to be a convener, bring together multi-sector partners, and to build bridges to decision-making spaces that the community is not often invited to do, as well as providing technical assistance, providing data to guide efforts, and other support that is needed and voiced by the community. I recognize that government for a long time, and still continues to do so, is to come into a community with their government cape on and say, well, this is how we're going to do this. But is it an ineffective approach? As you all know, it's an ineffective approach. In order to be intentional in designing our program, after looking at the data, is to understand the landscape. Overdose prevention was new to public health, so prior to receiving the funding in 2019, we had no formal overdose prevention efforts. Occasionally, we would look at overdose data and produce reports on it, but there was really no overdose prevention work. But we do recognize, because this was new work to us, we recognize that there are champions leading this work. So it was helpful to conduct community partner interviews, community asset interview to find out what was going on in the realm of overdose prevention in Riverside County and what are the gaps. We compiled that information and hosted 3 overdose prevention collaborative series virtually based in different parts of the county, to review this and to better understand best practices, what is currently ongoing, and what are the gaps, so this can guide our work as public health department and see how we fit in and can continue to contribute to this ongoing work and not reinvent the wheel or call the shots, so to speak, but really to understand how the role of public health can be helpful in overdose prevention work. Ultimately, our final product, the strategic plan that is reflective of community voice to guide public health work. And as mentioned, we're all part of a puzzle. Our steering committee includes all these different groups, plus some. We're continuing to grow. And what we want to do is, build sustainable change. So when I think of multi-sector partnerships, I think of building trust. It can be done with a community-based organization or a different sector, but building trust, finding common ground is essential for multi-sector work. One area that we've had to navigate through is building a relationship with our sheriff's department, particularly the coroner's department. They are an essential partner when it comes to receiving overdose death data. I think on both sides, with any partner really, there is a hesitancy to share data. We've been able to work with the sheriff coroner to the point where we have a co-located crime analyst in public health who's dedicated to working on our program. And because of this, we've been able to enhance timely data collection on overdoses to the point where we now get daily suspected overdose cases, which is helpful in identifying an outbreak. It's been a growing experience, and I think for both sides to learn public health speak. And ultimately, I would say that we have a crime analyst who understands the public health perspective. Sometimes building trust involves going out of our comfort zones and having candid conversations, and that for us included identifying the elephant in the room as to why public health was weary with working with law enforcement, and likewise their hesitation with working with us. There's been a lot of multi-sector work on changing the narrative on substance use. Our crime analyst at the Sheriff's Department has helped us convey messages and dispel myths about the syringe exchange programs and identify common misconceptions on harm reduction among law enforcement sector and just generally. Collectively, we focus on changing our language when we talk about substances and overdoses, especially using person-first language. Things for us are moving forward. We are continuing to identify ways to expand our multi-sector partnerships. One gap for us is partnering with people with lived experience, people who use drugs and or people who have lost loved ones from overdose. We want to continue having conversations, sometimes difficult conversations to build trust among partners and to also change current narratives and reduce stigma related to harm reduction, substance use, and others. To continue developing a list of policy and program recommendations based off our overdose fatality review team and other surveillance efforts through our overdose fatality review that is applicable for multi-sectors and not just public health. And then also to continue to find ways to increase access to resources, housing, regardless of drug use. Here's another quote from a steering committee member. I just hope that in Riverside County, we can come up with a response that comes out of all ROTA activities that are innovative, that can be a model for other places, and really rethink our whole response to overdose. So I assume Dr. Penny shared this slide, and you all know this sitting in this room. But when we look at the data, it highlights the need for multi-sector collaboration to really address social determinants of health and upstream causes of overdose. When we look at the root causes of overdoses, it's really a complex issue and can be linked back to systemic institutional policies and practices that have failed people. Historically, there has been a racist response to overdose substance use through the criminalization of drug use instead of substance use prevention, harm reduction, or treatment. The war on drugs and drug criminalization has and continues to disproportionately affect low-income and community of color, specifically Black African-American communities. It's also important to think about the barriers to housing, social services, and especially among those who actively use drugs. So harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction incorporates a spectrum of strategies that includes safer use, managed use, abstinence, meeting people who use drugs where they're at, and addressing the root causes of use. Addressing the root cause of use is putting the focus on the whole person rather than their drug use. It recognizes social inequalities, for example, past trauma, poverty, racism, that impacts people's vulnerability to and capacity for effectively dealing with drug-related harm. Harm reduction is also a movement for social justice built on the belief in and respect for the rights of people who use drugs. Because harm reduction demands that interventions and policies designed to serve people who use drugs reflect specific individual and community needs, there is no universal definition or formula for implementing harm reduction. The opposite of this is abstinent-only programs, and we all know how that works well with sex education. And so again, you know, when I think about harm reduction, you know, I'm a big fighter for harm reduction and helping people who are current in their addictions. But also, can you imagine, like, if we lived in a world where law enforcement worked on harm reduction strategies, or our child protective services focused on harm reduction, or other groups just worked on harm reductions as opposed to just trying to take the legal approach and breaking up families, causing additional family trauma going on. This did not load. So some of the evidence-based strategies is, you know, access to naloxone. I wonder if it's a movement one. So there's access to naloxone, access to medication treatment for opioid use disorder, remove prior authorization requirements for treatment of opioid use disorder, opioid use treatment in criminal justice settings upon release, initiating medication for opioid use disorder in emergency departments, fentanyl test strips, 911 Good Samaritan laws, and syringe services programs. Dr. Silverstein is somewhere here, and she has all the research studies related to how effective those programs are. So this is a slide just right now, just for a moment and a little bit of our workshop-y type of things. But there are some questions here. It's a good time for reflection and maybe think to yourself, when you picture a doctor in your head, do they look like you? Do they talk like you? What does a person who used drugs look like? Was there a time you felt uncomfortable with someone's sexual orientation or sexual practices? How did your parents or caregivers talk about skin color? What situations do we see as dangerous and why? What is an environment I find myself most comfortable? Who else is there? And what does power mean to you? What people in our society hold power? What people within this organization hold power? Just take a moment to think about those questions. One of those is the flight attendant. So for my next part of this presentation is focused on stigma. And so what is stigma? The definition of stigma, the dictionary definition, is a mark of disgrace associated with a particular circumstance, quality, or person. And the synonyms for stigma are shame, disgrace, dishonor, humiliation, and bad reputation. So this is a quote from the late, great Bell Hooks. Shaming is one of the deepest tools of imperialist, white, supremacist, capitalist patriarchy because shame produces trauma, and trauma often produces paralysis. And we know trauma is the root cause of addiction. So then what does stigma do? It makes you feel alone in the world. It makes you feel that you're the only person that experiences this. It makes you feel like you need to hide. And addiction thrives in isolation. So there's 4 different types of stigma. There's public stigma, which is people's social and psychological reactions. There is self-stigma, which is the social and psychological impact of being part of a stigmatized group, which perpetuates negative beliefs and feelings associated with the stigmatized condition. There's stigma by association, which when I was learning about this, that was something that I didn't really realize was a thing, but then when I read about the definition, yeah, it is a thing. It's social and psychological reactions to people associated with a stigmatized person. For example, if you have a friend or a family member that has a struggle with addiction, and that if you are there for them, others may see you as equal, or perpetrate stigma towards you. And then structural stigma is the legitimation and perpetuation of a stigmatized status by societies, institutions, and ideological systems. So some other questions to think about, and this is not a slide, but when we look at different groups of people and how stigma is affected, so think about race and ethnicity. How do addiction stigma levels vary across groups? I mentioned we received this funding under the former president's administration, where our numbers were showing that a lot of people who identify as white were overdosing and dying, and we received this massive wave of funding. Stigma. How about age? How do addiction stigma levels vary across the life course? I mentioned we see a lot of headlines about high school students or other younger people who overdose at school or in other environments. And that's where all the headlines are, and that's where the attention is. Social status. How do addiction stigma levels vary by education level, income bracket, or specific occupation? I mentioned that 1 out of 4 overdose deaths are in people who are currently unhoused. Where are the headlines about that? Where's the action for that? I'll skip this slide because Dr. Penny covered this very well, but again, we all have bias, and out of that bias comes the stigma. Am I allowed to, for the workshop part, can I have people answer right now, or do we have to wait till the end? Okay. So up on here are some, we're trying to speak about person first language. So, historically, maybe we would have said someone is mentally ill, but what's another word we could say instead of mentally ill? A person first. Yeah. How about and so instead of like depressed or schizophrenic, what can we say? Or ex-addict or clean. How about drug or alcohol abuse? Substance use challenge. There's some, and I assume you're going to share the slides and things. So all examples of instead of using how we used to, and it's really hard. It's a learning experience for me too, and I constantly self-correct myself. So it's not like we're all going to be talking in person first language, because that's not how we were raised. But these are just other versions to use, and sometimes it sounds a little bit awkward using person first language, and you're using a lot more words than just saying the word, but it does take a little work. So the language you use to talk about substance misuse shapes how the public views substance use disorders, and it perpetuates negative stereotypes. So we have the power to either perpetuate negative stereotypes or challenge them. At the macro level, stigmatizing language has the power to decrease public support for prevention programs and decrease public support for prevention and treatment programs. So again, we have some examples up here, and use person with a substance use disorder as opposed to addict or junkie. Now, I have, people who do suffer from addiction may call themselves an addict. It's their power that you could call yourself whatever you want. But when you're talking about someone else, we try to use the person first language. Testing positive on a drug screen instead of like dirty or failing a test. Person in recovery instead of former addict, etc. Again, some more examples. And yet some more. So there's a lot of different ways, especially in the addiction and substance use fields, where there's a lot of ways that we could use person first language. Now, I didn't realize this room would be so big, but I have some case studies and I have some handouts, and I was going to have you all break out into groups, and it's like you could be in a group or small groups. So I have 15 handouts, so we could divide in 15 groups or just cluster around where people are seated. And there's 4 scenarios, 4 people: Marcel, Jim, Joy, and Lexi. And how would you encourage harm reduction practices and or stigma reduction in these people? Okay, no, okay, okay, you can do Lexi. Okay, Joy is going to start.
Hello? Okay, great. So we did Joy, and when we were assessing her needs, it stated that she had, she was hurt by her mother's reaction to her suicide attempt, which conveyed frustration and anger rather than love and compassion. So in her program, if we were there in her situation, we'd want to assess her needs, like what are her expectations from this program? And Tanya mentioned a really good point, is that she lacks community. And the first thing would be to address her immediate community, so her family structure. What can we do to support you in that? And just coming to the root cause, because we don't want her, she was brought by her mother and stepfather, so we don't want her to feel like she's forced in this situation. So coming to the root cause of her family trauma and assessing her needs, because she's drawn to an individual named Nick because she feels that he demonstrates the love and attention that I'm not getting at home. So that's a clear indicator that she has those root causes that we really need to address from her family.
Thank you. Did any other groups review Joy? Want to add anything? Okay, let's move to Marcel.
Okay, so we were discussing Marcel, and it was really a group effort. We all had great input. What we discovered is that Marcel has multiple issues going on. And so our strategy was to address what he feels his needs are by using solution-focused methods, and meet him where he is. Don't assume anything. And so we were going to first list, what's working for him. Tell him what we were first going to have him tell us what's working for him. and then what's not working for him. And then we were going to build off of what's not working for him in his eyes and see how we could help him eliminate some of those with the goal in mind of helping him find himself, helping him get into recovery, helping him get into housing, helping because it's just so much going on with him. And then we also addressed the fact that he did not want to be tested for AIDS. So for that reason, and for that thought, we decided we would just ask him the question, what's the worst thing that can happen if you were tested? And then our response and assistance would be based on his answer to the question. And that's pretty much, did I miss anything?
The other thing we wanted to do was to place someone with Marcel that can relate to him, someone that looked like him, someone that had similar experiences, because we don't want him to feel like he's being judged.
Thank you.
No, it's okay. No. So all these strategies we were talking about and we spoke about and discussed all encourage harm reduction practices and taking that stigma off of who he is or what he's gone through, what traumas he's experienced. And so taking those things off and saying it's okay to be who you are, and we're here to support, or that mentor from yesterday, that mentor or that person from that agency that's assisting him, saying it's okay to be who you are, and we're here to support through the process.
Another thing that we want to add is self-determination. At the end of the day, an individual is going to decide what they want for the future, and then we're there just to provide what he needs.
Okay, did anyone do Jim?
So we had Jim for some of the stigma reductions. Jim was a longtime user, we found. He'd been using since he was 16. He had just been released from jail. Some stigma reduction. He had been seeing a prostitute, so we talked about having open conversations with him about getting tested for HIV, STDs. Something that our group brought up that was really great was community for him, getting him into maybe other programs, something that he may be passionate about. He used to use heroin. Now he was a first-time fentanyl user, and he loved that like immediate high of that first-time use rush. Somebody brought up getting him like a peer, somebody, and I know Inland Empire Harm Reduction does this, they're peer-led. So really working with him from, somebody that has been there before, like a couple of other groups mentioned. Maybe finding him an interest, maybe like a friend doesn't have to be necessarily like a love interest, but that community member that can really work with him. And we thought that was important. Am I missing anything?
Okay. I was saying, because a lot of times we look to organizations, but just looking at us individually, what can we do? I brought up seeing some of the community members that are unhoused and how the shame can come up where you don't want to be associated or have that interaction. Like, what can we do as a person? Not always just depending on organizations to do it, but because a lot of this starts individually. So what are we going to do personally?
Thank you. Now so those examples were probably more extreme and that but they're real life examples too as well. One of the things that I do like to point out is that we can all make a difference to reduce stigma right now. It's something that we can make an impact right now. A lot of the upstream, systemic, and other issues will take a long time to address and correct, but action that we could do right now can help us, it helps me, and hopefully helps you make an impact and action and help you continue the good work you're all doing. So some of these things that we could do right now is correct negative language. We could speak out against negative behaviors and statements. And we can make sure that images used in communications show diverse communities. And then finally, we could promote harm reduction. You know, I'm a big supporter, proponent, cheerleader for harm reduction. My goal is that someone, a person, your loved one, your friend lives for another day, so then they have an option or an opportunity to change something in their life the next day. And harm reduction, you know, the ultimate goal of harm reduction is to reduce misery, reduce suffering. Why do we want to cause additional trauma? So this is the end of my formal presentation, and then I am going to invite a very special guest up here to share an example of partnering with UCR and partnering with the community on several different projects. I mentioned, you know, prior to the pandemic, we were working on trying to work with the county to allow syringe services programs in our county. You know, our big roadblock was the Sheriff's Department. And as I mentioned, we have a crime analyst, a Sheriff's Department employee sitting in public health. And actually what he was able to do is he took actual words he hears from his colleagues about why needle exchange programs or syringe service programs are not good. Like, we'll find needles all over soccer fields. He has colleagues who say they walk in soccer fields and there's needles all over soccer fields. And then partnering with Dr. Jen Syversten, who I'm going to invite up here right now, she provided all the academic background information to counter some of those myths that Brian Gray, who was the crime analyst at the time, was able to pull together. But what I'm bringing Dr. Syversten up here to discuss is right now we're partnering on an NIH research program that she is leading, and it's a partnership between public health, EMS, and then UCR Department of Anthropology. And I don't know, just want to give a high level of the project.
Hi everyone, I'm Jennifer Syvertson. I did not realize that I was a speaker today, but thank you for inviting me down, Wendy. I want to start off by saying I just want to appreciate Wendy so much. We have a champion in our local health department for harm reduction who really cares deeply about these issues and addressing these issues in our community in a more holistic and multi-sectoral approach. And so it's really great. It's been great to have this partnership. I guess I'll step back and provide a little bit of background. I moved here in 2017, so I'm a relatively new person here in Riverside County, and how much has changed in this short period of time. And Wendy in the health department has been a huge champion of this. In about 2019, we had an event at UCR, and we invited the health department, community-based organizations, students, faculty, other researchers who have worked in harm reduction for years, and we had this beautiful event on campus. And Wendy was there as a participant in this event, and we talked about harm reduction. We began to talk about the good things that come out of that it reduces stigma, that people who access services are more likely to enter treatment, that it's actually the opposite, where there are harm reduction programs, you find less syringe litter in your community. It reduces stigma. It enables people to have linkages to other kinds of services like housing and social services, things like that. We had this great event, and then COVID happened, and the world shut down. But these efforts didn't stop. And so I've also been involved with Inland Empire Harm Reduction, which has worked with the health department. And during that time, we became the first authorized syringe services program in Riverside County. We provide naloxone distribution and education and Those services have grown so much over time, and the involvement of our staff and our volunteers with the health department activities have grown over time as well. So now our staff are out doing trainings for different organizations. They have an active voice in shaping policy. So those linkages have been really, really important. On the other side, we have the research side. And so there really hasn't been a lot of research about substance use, about overdose in the county. And the data that Wendy has shared, this is some of the most detailed data that we've had to date in terms of the epidemiological trends. So what we have done, I emailed Wendy and I said, you know, are you interested in research? And she wrote back immediately and said, yes. So we partnered on this grant that we got funded from the National Institutes of Health. And what we're doing is combining the epidemiological data, so from the health department, from EMS, looking at those very detailed indicators, and there's also a geospatial component to that my colleagues are working on. And so we're able to do a fine-leveled analysis of that data and a mapping and a modeling of that data. So we can look at, okay, across our huge county, which we know is very diverse, what is happening? Where are the overdoses clustering? And what are the factors that are associated with overdose in these different locations? On the other side, we are working to get at exactly what Wendy brought up, the lived experience of drug use. So we're conducting surveys, we're conducting in-depth interviews, we're conducting field work. We're working a lot with the unhoused population locally and really getting at these issues and what is the trauma there? What is the reason why we're seeing these increases in overdose? What does the response look like? Which is sometimes not always great when law enforcement is involved, right? So we need more community-driven kinds of responses. So we're collecting that data, and we hope to put these different data sets together and have a more holistic understanding of what's happening in our county in order to better address these issues. And so this kind of project is bringing the health department together with a community-based organization, with academic researchers, with community members to give everybody a voice at the table and figure out how do we better address these issues and make our communities healthier.
And I just want to end on this quote. The opposite of addiction is not sobriety. The opposite of addiction is social connection. And I think, you know, with the COVID-19 pandemic, a lot of us were socially isolated, you know, traumatized, et cetera. And we need to heal, and we heal through connection and through partnerships and sharing our stories. So thank you for being patient with me in one of my first few presentations post-pandemic. And it's a lot easier doing a presentation on Zoom where you have your notes there, camera there, and you can just do it really easy. And so thank you. And I'm excited to hear the rest of the presenters today. Thank you. Do we get questions? Yes?
Okay, I'll repeat it. In regards to the unhoused population, what are some appropriate questions that we can ask them directly to assess their current drug use or past?
Well, I think just the, how are you? How are you? Do you need anything? How can I help?
Thank you.
So hello, everybody, and welcome back to the afternoon session. My name is Tanya Nieri. I'm in the sociology faculty at UC Riverside. I'm not Yolanda Moses. I wish I were, but I could not fill her shoes. She is too great a woman, but she was called away, so I am stepping in. So I'm going to introduce this particular session, which involves presentations and research and some, hopefully, dialogue and discourse with all of you about that. So some background, the Health Disparities Research Center at UC Riverside aims to create a rich, interdisciplinary, diverse, and collaborative environment for health disparities research, infusing community-engaged research methods into the academic culture and equipping investigators and community with tools and training to improve their extramural funding success. That's money, money, money. These fellowships are open for faculty, postdoctoral fellows, and graduate students who are pursuing health disparities, community-engaged research. Today, we're going to hear from 3 of those people who have received fellowships. And if you're curious to learn more about their projects or some of the other projects that will not be presented here today, you can visit the HDR website listed on the program that you received today. So let's get started. Our first presenter is Dr. Jean Russell, who is an assistant clinical professor in the pediatrics department at UC Riverside. And she's going to be talking about a project that is one of the clinical projects, and the title of that is Addressing Health Disparities Through Virtual Care to Prevent Postpartum Depression. Thank you.
Okay, it does work. Hello, thank you for having me here. I managed to avoid presenting the last 2 years, but finally I have some data to present, so I'm happy to share. So my project is about trying to prevent postpartum depression through addressing health disparities. I have no disclosures. Just an overview. This is basically the topics I'll be talking about. All right. So background and significance. So postpartum depression is a large problem. It's probably the most prevalent maternal morbidity associated with childbirth. Before the pandemic, it was estimated that in the U.S. alone, it was somewhere between 800,000 to 1 million cases of postpartum depression a year, and that's likely an underestimate. The major studies that have come out since the pandemic showing kind of pandemic rates is it has increased 3 to 4-fold. Also likely, for some of the reasons I'll talk about, an underestimate. So postpartum depression has effects wide-ranging beyond just the mother, effects on the child, the future generation, development, partner mental health, basically the whole unit permeates through society. So the main risk factors for postpartum depression are risks, previous history of any psychopathology, especially during pregnancy is a major risk, low social support, stressful life events, and poor relationships with partners. Mothers of lower socioeconomic status tend to be younger, have lower income, less resources, lower education levels, less stable employment, lower social support. They tend to be more single mothers, and they're less likely to have postpartum care or any medical care. They're also less likely to be screened or treated for postpartum depression, even if they are diagnosed. So it is not surprising that women of lower socioeconomic status are at much higher risk for postpartum depression at baseline because of some of the other factors involved. They also have less access to healthcare in general and less access to mental health services. So, and then the pandemic came. So I saw this as kind of the perfect storm. So postpartum depression plus the issues of health disparity already, and then this new stressor that is exacerbating these access to care and issues already. So it might seem odd that a pediatrician is doing research to try to prevent postpartum depression, but from my standpoint, the way what I saw when I first came to Dr. Lowe with was I saw a huge increase in postpartum depression, especially among my new first-time mothers during the pandemic. And it was probably the most pronounced thing that I have seen in terms of a change. And we were all waiting for big changes. I didn't see a lot of other big changes in pediatrics, a lot of mental health, other stuff later on. But very early on, I was able to see that. And while my numbers were likely anecdotal, I doubt that it was, not. My theory was that this was probably happening everywhere. So I was the only one that was seeing these women too. So I felt especially helpless to help them because they're out of my range or age population. But they're coming into me repeatedly because they care about their babies. And they are filling out these surveys and they are very much hurting. So I actually got to the point where I was calling some of the OBGYNs and being like, hi, like how can we bridge this gap? Because some of these mothers weren't even following up with their OBGYNs, but they were prioritizing their children's care. So with this thought, Dr. Lowe kind of pushed me into thinking further along why this was happening and what we could do about it, or why I hypothesized this was happening. So I dug into the research, sort of looked what has been done with postpartum depression, and what works in preventing and treating. So it was shown that telephone interventions early in the postpartum period are effective in preventing postpartum depression symptoms. It's showing that group and individual approaches can work in treating postpartum depression and in preventing it. The other thing that happened during the pandemic was that Zoom kind of came to the forefront. I think before the pandemic, I would have been skeptical that as many of my patients' parents would have had access to Zoom, but that was clearly apparent to me by all of the telehealth visits that I was doing, that it was very easy for most of the population that I served to get on their phone and download Zoom, or not even download. So while we've had, there haven't been any studies that have looked to see if sort of virtual sessions could prevent postpartum depression in these women. And it's also, another benefit is it's free, and it bridges some of the issues that some mothers have in terms of seeking care, getting care, seeking support in terms of transportation, childcare, and these are issues that were well before the pandemic. So, all right. So stage one, which we've completed already, was my community-based approach to develop the intervention. So in stage one, I sought out mothers that had a history of postpartum depression and also community leaders that had run support groups specifically focused on postpartum depression and the early postpartum care. And I interviewed them in Zoom interviews to see what the best format was if my population was unique, to make sure I was actually meeting the needs of my population, which I'm out in the Coachella Valley. So initially we had some trouble because some of the parameters were stricter than should have been, but so eventually we were able to recruit enough people. So I'll talk about what we got out of that. And now we are in stage two, which is the pilot randomized control trial. The hope is that after we analyze the data, that this thing that we've produced is something that can be reproduced on a larger scale, and we can do a larger randomized control trial to show that this can be helpful. Okay, so this is for stage one. I interviewed 7 women with a history of postpartum depression, discussed with them, the main topics were what topics that they thought were important to have in a sort of support session like this for newly postpartum mothers. What logistics in terms of what time of day, what time of week, how long, how many people in the groups, and also features about Zoom. Should everyone's camera have to be on? Should the chat be open? Should the waiting room be open earlier? Things like that. And I wanted it to be, I could have sent out surveys, but I really wanted to make sure I wasn't missing anything major, so that kind of je ne sais quoi of it all. So we recorded all those. We also interviewed 2 community support group leaders, one that was a nurse that ran support groups out of Desert Regional Hospital, and one that's affiliated with one of the local groups, which is also one of our community partners. All right, so community partners. So I have about families. That's the one that I was talking about. So this is a nonprofit that is in the Coachella Valley, basically supporting families from the perinatal period through the first 5 years is its goal. We also spoke with the Postpartum Support International representative for the Coachella Valley, which is an international group that looks to increase awareness among public and professional communities about the emotional changes that women experience during pregnancy and postpartum. And then our other community partner was Caring for Women, which is an OBGYN group that shares a parking lot with us and sees a similar patient population in terms of from Medi-Cal through. So, stage 2. So this is where we are now. So we are in the midst of recruiting. I think I've recruited something like 20 participants so far. So maybe close to finishing. I have to look at the data and see how many have. It looks like most people are actually filling out their surveys. So I'll talk about what happened from all of this, the information that we got from stage 1. But basically the way that we set up stage 2 was that they're randomized into either an intervention group or a control group, and then everyone is given 5 sets of surveys. The first set of survey has a lot of demographic stuff, and then the other ones have the Edinburgh Postnatal Depression Scale, State Trait Anxiety Inventory, and the UCLA Loneliness Scale. And then we're checking that at the 2-week, 4-week, 8-week, and 12-week interviews postpartum. Comparing them. We also did the demographics. I wanted to compare we did the demographic survey for the women interviewed in stage 1 to see if they were actually representative of our pilot population. Okay, so this is as discussed, the Edinburgh Postnatal Depression Scale, the most widely used scale in both clinical medicine and in research. So we only use it in English, but it's in a ton of languages, very well validated. The State Trait Anxiety Inventory, so postpartum anxiety and postpartum depression are very much overlapping, intertwined, hard to distinguish where one stops, the other one starts. So this State Trait Anxiety Inventory, it differentiates between the temporary condition of state anxiety and the more general, long-standing condition of trait anxiety. So is this anxiety that you're getting from this current situation, or is this just anxiety? And then the UCLA Loneliness Scale, I just thought was, as far as I could tell, it was the best measurement of perception of social support, which I wanted to see. That's a big thing for postpartum depression and for the pandemic. And okay, so preliminary data. So from the people that I interviewed, the main topics that came up were self-care, sleep. These are topics that they want to hear about in postpartum sessions. More information on postpartum depression itself. Loneliness, other emotions that happen perinatally, relationship changes, expectations versus reality, support systems, breastfeeding, birth trauma, and going back to work were topics that they all liked. So I was able to consolidate those into my 4 topics for my 4 support sessions. And there's 4 support sessions that happen. It happens weekly for a month after birth. So the first one is postpartum self-care, and then there is perinatal emotional complications and support systems and relationships, and then transition to parenthood. Okay, so the Zoom features that were discussed, they wanted most people wanted the sessions to be open before and after the meetings, the chat feature to be on during the before and after, not during. Off during the meetings, camera on, the meeting duration about 60 minutes. So far, the only issue that I have found since I've been in stage 2 is that many women aren't coming to the sessions. So I've only had 4 women that have come to all the sessions, but I'm interested to see if the women that have been invited to the sessions, maybe just being invited can have an effect too. Yeah, I have lots of presentations that you can't read.
Thank you, Dr. Russell. We're going to have questions at the end, so if you have them, write them down. Thank you, Dr. Russell. Okay, our next presenter is Danielle Stevenson, who's a graduate student researcher in the Department of Environmental Sciences at UC Riverside, and she's going to be presenting on a project that is part of a type of project called the Continuity Collaboratory Project, and the title of it is Field Testing to Determine Best Practices for Community-Accessible Remediation of Soil Contamination to Reduce Metal Exposures.
There we go. Okay, cool. So I'm going to talk a bit about a project I've been working on over the last few years that aims to reduce health disparities caused by metal exposures from soils and by testing remediation options in partnership with communities affected and living near contaminated sites. So through these studies, we aim to close the gap between community needs, scientific evidence, and policies needed to promote environmental justice with regards to these exposures. So soils are a major exposure pathway for metals, and many socioeconomic factors increase the risk of exposure and the likelihood of living near a contaminated site. Brownfield, just in terms of terminology, is a term that refers to a contaminated site where no further development can happen. It can't become a park or housing or anything until the pollution on that site is addressed. And this is a really old map that's thought to be really, really conservative, but just showing basically these contaminated sites across the country. In California, there's over 200,000 of these contaminated sites. Really, really conservative estimate, there's probably 6,000 acres or so of contaminated land in just LA. And these sites sit for decades without being cleaned up because the current method of cleanup involves just digging up all that soil and dumping it in Arizona or Nevada, and then bringing in clean. I know, it's like, and it costs millions of dollars. It increases exposure through dust coming off these trucks. There's like climate change impacts, and it's super, super expensive, and it doesn't solve the problem. It just moves it somewhere else. And then they dig up clean soil from somewhere and bring it in. So obviously for 200,000 brownfields in just California, this isn't a feasible method. And again, just these sites just sit for decades and decades. On average, there's one site a year in the country that gets cleaned up. So it's a big problem. And in working with communities in LA, living near these sites, they're exacerbated because, again, these sites are just blights in the community that sit for a long time and spread toxic dust everywhere. So and many urban brownfields can't even be cleaned up through dig and dump because they're so urban, right? So there's housing, maybe all around them. You can't get the trucks and excavators in. So an alternative is biological remediation, which just works with living organisms to clean up soil. When you're working with plants to do that, it's called phytoremediation. When you're working with fungi, it's called mycoremediation. And before I move on, I'll just say the reason we're all excited about biological remediation as an alternative is that it actually addresses the problem. It does so on site, so you don't have to dig up that soil and dump it somewhere else. And it's so much cheaper than the conventional remediation, more sustainable and often preferred by communities, and draws on skills and resources that communities often have within them already. So there's a couple specific types of fungi I'm really excited about including in these studies. So plants have been tested before, but often fungi have been overlooked. So there's some fungi called decomposer fungi that actually can degrade diesel and other organic contaminants. And then there's these, it's a big mouthful, but arbuscular mycorrhizal fungi are fungi that help plants grow, and they can actually help plants take up more metals like lead so that they can be removed from the soil. So when you put that all together, you have this approach that we're testing. So we have beneficial decomposer fungi dealing with the organic contaminants like diesel. We have plants, native plants that we've found are taking up high concentrations of this lead and other hazardous metals, and they're being helped by these mycorrhizal fungi underground, helping them do that. So yeah, these are the different treatments we're testing. As I said, native plants we identified from a previous study are good at taking up these metals of concern with the arbuscular mycorrhizal fungi and with decomposer fungus. And we're testing it at 2 different moisture regimes. One is a droughted condition with no water, and one is a regular irrigated condition. So we have 4 brownfields that are participating in this study with many incredible community partners and also regulatory and governmental partners. So the City of LA and its many agencies that address or work with contaminated sites, as well as the Department of Toxic Substance Control, which is like part of the EPA, the Environmental Protection Agency, and then a number of community land trusts and community urban agriculture groups, things like that. All of these sites, so 2 of them are going to become, well, actually, they're pretty much all intended to become either green spaces, parks, and or community gardens, and or some of them have some low-income housing that is part of the plan as well. And these sites are huge. So again, going back to that feasibility piece, I mean, Taylor Yard is 100 acres big. Slauson site is 7 acres. So yeah, just big old sites. Yeah, just kind of showing, I mean, if you look at the picture in the top left and then the bottom right, that's a Taylor Yard site. So it's an old rail yard. It's just pretty bleak, right? 100 acres, like super contaminated. I've never seen levels that high for lead and diesel. The Slauson site in South Central LA is on the bottom. And then the pictures that have a little more brown in them, you're seeing them after we set up these different study plots. Nothing is growing yet. We had just set them up. And so, how it's going well. It's just incredible to see the transformation of these sites in such a short time. So, plants are growing. There's birds and butterflies and life in the soil. You can put a shovel in the soil now, whereas you couldn't before. And this is Valeria, who's here. It's an amazing assistant, and we're harvesting one of the plants. It's a sunflower relative to test it for metal uptake. These plants grew like 10 feet tall and had really cool deep roots. So we are seeing that we seem to be reaching some of our goals. So in the red, you're seeing these are just different plots. That was the initial concentration of lead in the soil. And in yellow is the concentration after 6 months of treatment with these plants and fungi. So basically, you can see that the plants did remove the lead. That's good. There's only 3 plots currently for this Slauson and Wall site that are still above the regulatory limit of 80 milligrams per kilogram. We also had over 50% reduction in the hydrocarbons, so the organic contaminants in the soil, after only 3 months of treatment, which is very good also. And I just was working with really new data, but just starting to look at, after 6 months of treatment, what is the difference between these different, are these fungal treatments making a difference? Is there a difference between the plants? And just what we're seeing preliminarily is that, the fungi really help. So in general, both plants, when treated with either the plant friends, mycorrhizal fungus, or the decomposer fungus, took up more lead. So that's good. That's what we were hoping. And we've done a lot of community engagement and other types of stakeholder engagement through this process. Real highlight was we ran a youth program with high school youth from the high school near that largest, most contaminated site in LA. So you can see the school from the site. So this year we had 10 youth get trained in bioremediation. They helped collect data and sample and learn all about that. They got their HAZWOPER training. And this is a picture of them there, getting their certificate, doing their final presentation. It was just really rewarding. Some of the youth said that they weren't planning to go to school after, and now they want to go into bioremediation, and they're planning to go to college, and we're trying to find a way to hire them. And the program will run next year too, and we've had 85 applicants already. So that was just really rewarding. And they all said too, like they all live in that neighborhood. They're like, I didn't know that it was this way. And so then they, talking to their families and stuff. And I've been getting a bunch of their, family members and teachers and stuff reaching out to be like, hey, can we, do some testing? Like we're worried now about, about our neighborhood. So, and there's just, there's just been so many folks involved in making this happen. So, thanks again to HDR for this award to support this work, and the City of LA, and then all the many collaborators and my incredible undergrads and research assistants like Cameron and Valeria and Andrew who are here today too. We have a little web page up, but my contact info is here too. Please reach out if you'd like to learn more or collaborate or something. Thank you.
Thank you so much, Danielle. So our last but not least presenter is Laura De La Reta, who is a graduate student researcher in psychology at UC Riverside. And she's presenting on a project that, if some of you were here yesterday, I believe it's related, right, to Kalina Mikalska's work? Am I right? Or is it totally different? Yeah, it's kind of related. So this is a third type of project that the center funds, which is a pilot interdisciplinary collaborative research award. And it's awarded to an interdisciplinary research work group that then focuses on research together. So the title of this presentation is Sociocultural and Emotional Regulation Processes that Contextualize Health Disparities in Latinx Children's Anxiety. Welcome and thank you.
Yeah, hi everyone. My name is Laura De La Reta. I'm a psychology student at UCR. I'm here on behalf of my advisor, Dr. Liz Davis, to talk about our project. So, sociocultural and emotion regulation processes that contextualize health disparities in Latinx children's anxiety. So in our lab, the Emotion Regulation Lab, we study children's feelings and how children manage their feelings. Ultimately, we want to help children feel better as they navigate their life challenges. And we use a multi-method approach, so we gather self-report data, observational data, and physiological data, so we can see how children, measure how children are managing their emotional experiences. And the focus of this project specifically is anxiety. So anxiety is one of the most common psychiatric conditions in children, affecting up to 30% of youth. And we want to know how to make children feel better. So this is Cynthia Garcia-Cole's integrative model for understanding factors related to minoritized children's developmental competencies. Although most research has focused on European American and white children's anxiety symptoms, growing evidence suggests that minoritized children, such as Latinx children, may have a heightened risk for anxiety symptoms. So this is in part due to environmental and social stressors. So for example, experiencing discrimination and prejudice, or even navigating acculturation. So we're going to zoom in on some parts of this model. So in our lab, we consider children's emotion regulation skills to be a mechanism that could contribute to anxiety symptoms or maybe mitigate those anxiety symptoms. So in other words, how children are managing their feelings could either increase feelings of anxiety or decrease. We also think that family values and practices and the ways that families talk about and discuss emotions and emotional experiences contributes to how children learn to do this on their own. So the way these things are treated in families can maybe help support children when they do these regulation skills independently. And research suggests that these family factors could be especially important for minoritized families. So the goal of this study is to understand the relational and cultural and emotional experiences of Latinx families in Riverside in order to help understand how children's emotion regulation skills develop and ultimately their anxiety. So children and parents will complete a variety of surveys about their feelings, their cultural values, and their life experiences, in addition to completing in-lab emotion regulation challenges. So for example, we have parents and children watch a scary movie clip. So think of like the whale scene from Pinocchio, if you know it. And then we ask them, what did you do? How did you feel while you were watching that? What did you do to make yourself feel better? And then we'll also have the parent and child have a conversation about it. So we'll get some real-time data about how parents and children might talk about these everyday emotion experiences. So in addition to having parents and children complete in-lab tasks using their emotion regulation skills, we're also developing in-depth interviews about their social and emotional experiences. So for my dissertation project, I'm really interested in family storytelling, something near and dear to my family. And I believe that family storytelling is one way that families might pass on information about how to deal with life challenges and life experiences. So parents will share in the interview whatever they're willing to share about their family history, stories they've heard, stories they share with their children. And this will help us understand the family's history and relational dynamics and how families are discussing and processing their lived experiences with their children. So ultimately, we think that the way families are talking about this, again, will kind of inform how children are making sense of their own life experiences. So this is an important gap for developmental science to address because we think, again, that storytelling could give children a schema for how to make sense of their own life. So by understanding how families are talking about their experiences and maybe passing on this regulatory information, we can further unpack what's helping children mitigate this anxiety and what might be contributing to anxiety symptoms. So we study developmental psychology, but we're taking an interdisciplinary approach. So we're collaborating with experts in political science and Hispanic studies because we think this work will have implications not only for families in Riverside, but also for science and policy more broadly. So we're actually about to start data collection. So any and all feedback or questions or comments you may have, I'm happy to hear. And yeah, thank you so much for having me. It's an honor, and I'm humbled.
Thank you so much, Laura, and I apologize. I realize I conflated Liz Davis's lab with Kalina McCaulif's lab. And that's because they're two psychologists, right, both focusing on psychological outcomes and looking at the processes, and both in Latinx populations, am I right? Oh, see what I mean? Yeah, she's everywhere. Anyway, so I don't want to waste any more time talking about me. The floor is now open for questions, and I invite our colleagues to sit up in here, and if you want to bring your own mics so that you've got them.
I have a question for Jean. Why do you think women don't come to stage 2?
I've found that if they don't come to that first meeting, it seems that they're not likely to show up at all. So I think that, I mean, there's a lot going on. I think it's a little intimidating coming to a support session, especially coming to one over Zoom. So just taking that plunge of doing it, yeah, I need to be careful about not talking so much about how the compensation isn't tied to attending the sessions, probably. I'm working on that.
Thank you. Other questions? Do you feel it could be contributed to not having social support?
Maybe the perception of not having social support. Because the women that do attend, I mean, there's children all over them, they're on their phones, they have their babies generally, they're feeding their babies. Like, it's a very open and welcoming situation, but maybe perceived that they wouldn't be able to contribute or focus.
So this is on Zoom, right?
Yeah, it's all
I'm
virtual.
saying social support in terms of not having the baby, because you're talking about self-care and being able to really focus it and have that be their time. Do you think that there's any, you know, like if they have someone to kind of take the baby for that time period that they're...
Yeah, that'd be ideal, but because it's virtual, the hope is that that isn't necessary always.
I'm sorry, I have a question for Danielle. So you were saying that there were three plots where the plants did not show that they were making. Do you know why that might be?
Oh, that's a good question. It's not that the plants weren't taking up the lead, but these sites have really uneven levels of lead. So it might have been that plot just had really high lead as a starting point. So the plants are taking it up, but it's going to take longer to get it down below the level.
Yeah, my question's for Danielle as well. Someone who used to have an office on a brownfield. So it's very exciting to see the potential transformative power of fungi, right? So what are the limits? What are the how far can this go in terms of being taken to scale, assuming that your results hold up and you're able to replicate them?
Yeah, I would love to scale this up more. This is already, I mean, so there's 3 sites and they're each from between like a quarter acre all the way up to an acre. So already kind of large. But yeah, the limits, so with metals, because they don't break down, we're just moving them around, right? So they don't cause harm. So if you're working with plants to like clean up metals out of the soil, the limit is that the metals can only be cleaned as deep as the roots can reach. So that's usually fine because most of the time these sites have the most metals right in the very surface of the soil. But you know, that's a limitation. If you have a site that has like 30-foot deep metal contamination, these approaches probably aren't going to work just as is, right? You could do like a staged, you know, treat the top, get that excavator and like dig up the bottom and flip, you know, but yeah, there's some limitations there. Another one is that, I mean, even though we're working with native plants in general, it does seem like it all goes better when there's water, but we're in a drought, and some of these sites, I mean, especially that old rail yard, it's 100 acres. It's been like impossible to get water there. Right now we're having water trucked in. The other sites were able to connect to the fire hydrant and get water that way, but yeah, water is a limitation. And then, I don't know, we need a workforce, we need people who are trained to do this new approach too. The other major limitation though is the sort of policy regulatory side. It's kind of, it's amazing that we were even able to get approval to do this, because initially the regulator told me that we couldn't field test a new method of remediation unless it had already been proven in the field. So I was like, but how? So yeah, there's still a lot of sort of regulatory barriers to actually moving this from a study to like a pilot and scaling up.
I thought that was really cool. All 3 of these were just fabulous talks. I had the one question, it's right over here. I had a question, start with here.
great that it's concentrating into the plants, but then you said something and there were birds and there were animals, and I started thinking birds and animals and eating plants and dispersion. Is that a realistic issue, or is that something when you're doing this, you have to take care to, screen it off? What's your thoughts?
Yeah, usually the part that like butterflies and bees and birds are going after is the reproductive part of the plant. And because that is so precious, there's so many barriers that a plant will have to protecting that seed or fruit or whatever. So other studies I've seen, there is such a trace amount of, say, metals in the part that's eaten. I have been thinking about that. We are testing, we're testing all the parts in this study to make sure. The decomposer fungus forms mushrooms, and so we took care to harvest all of them and test them for metals, but also just like harvest them and contain them so that they're not getting eaten by squirrels and potentially dispersing metals at all. Although I would still expect those concentrations to be really, really small relative to like the amount that would be in the biomass, like the living biomass itself.
That's cool. And then I had another question, sort of following up what you heard. Although everybody said they wanted the camera on prior to getting it, then there's the reality you have the kids and just having kids and being sleep deprived and don't have time to look like you brushed your hair, even have any clothes on. I mean, it's just really tough. Have you looked at another one where you do it with the camera off or camera optional, or also with a chat on optional for some folks just might not feel comfortable in the reality of displaying either visually or orally, sound-wise, what's going on in their domains for a lot of reasons. And so that's why I was just wondering if that might be something you would like to integrate in as another study. Because what you think you want and what you actually want might be two different things.
Yes, short answer. And telephone interventions have been shown very successful. There's a large study out of Canada that showed that, which is sort of just the talking part. I don't say up front that they have to keep their cameras on. So when I'm recruiting them, and we're pretty lax in terms of during the sessions, but the problem is to get them to that first session so that they can see that this is a pleasant, comfortable situation, not something stressful.
Thank you. We just have one more, another question back here.
Thank you. I apologize first. I didn't get your name. You're doing the postpartum.
Jean Russell.
Okay. Hi, Jean. Question. Actually, I have two questions. One is, what is the ethnic breakdown of your study?
I don't know yet, but it is. I'm hoping it's representative of the Valley. The ethnic breakdown of my office, I could probably figure out more easily, but it's probably primarily Hispanic, but with a scattering of everyone.
Okay, and then the second part is that I did not see or hear is how are you factoring in doula services in this study?
Funny that you mentioned that, because one of the main person that I've collaborated with is a doula, the woman that runs About Families. So I use doula services often in my work to help mothers that are particularly struggling, and there are definitely postpartum doulas, and some of it's actually covered by some of our managed care insurance companies. Well, doulas in general, I'm not sure the postpartum part. So that is something that I'm incorporating in general. It's not really incorporated in the study at this point.
Okay, I was just wondering if you would consider that, because I heard you mention about external supports and doulas, and not just postpartum doulas, because typically the postpartum doula is also the prenatal and the labor and delivery doula. And so as you decide to add more factors to your study, that might be something you might want to consider. And there are large doula organizations out here in Riverside County, I don't know if you're aware of that or not, that are already organized, and those that are still organizing to address the deficits in maternal care with people of color. And so that was my question, because I'm just trying to figure out how you could really come up with insight. If you don't know your ethnic breakdown, how you'll be able to come up with a conclusion. So that's all. I'm just asking because I didn't get that information from what you presented.
Yes. I mean, there's demographic stuff embedded in the study, so we'll find out if our patient population is representative. But another problem with where we are located, which is way out in Coachella Valley, is that there are not even a lot of doulas out there. So there's a shortage of everything. So a Riverside doula sounds wonderful, but that's probably not realistic.
Well, actually, there's a couple of them, and there are many more that are headed that direction. So I have your information. I think I have. You posted yours up there on the screen. Did you your contact information? Did you post?
No, I should though.
Okay. I can get your contact information, and then we can talk about it.
That'd be great.
Thank you.
We have time for 2 more questions, and this lady here had a question, and then this gentleman here had a oh, okie dokies. Everybody talk real fast. My question is for Lorena. I'm going to assume that your parent and child participants are willing and they understand and the anxiety a little bit. What can you do for the children whose parents do not believe in this disorder?
That's an excellent question. I think that's definitely one of the challenges that we see in terms of people seeking treatment. I know that was discussed in an earlier symposium. So I think I expect that might be a theme that emerges in hearing family stories. So seeing what kind of strategies that's related to that the child might use, that's really interesting to me. I could see that going 2 ways, maybe of the continuing kind of not seeking help, or maybe the opposite, right? It's the reason you do something is because your parents were like it, or you do something different is because your parents were like that. So yeah, I could see it going either way. So maybe a theme like that emerges in storytelling, and then maybe children either kind of continue using or having that same kind of attitude, or maybe they do something different to diverge from that path. But I think that's an awesome theme to be thinking about for sure. Thank you.
We're going to popcorn over here, then we're going to popcorn here, and then we're going to popcorn. That way we get back and forth and back and forth.
Thank you. This question is for Dr. Russell. On your slides, I noticed they attend 4 sessions, and then they also complete 3 surveys, correct? 5 surveys, okay.
Well, each set of surveys has those 3 in it.
Okay.
5 time points for those 3 surveys.
Okay, and my question was around compensation, because I saw that they were getting $10 per, I guess, is it per survey or per session? But I was just wondering, we've been talking a lot about adequate compensation for community. And for the amount of time that it sounds like that would be for a participant, $10 to me seems very, very low. So I'm wondering if you're thinking about ever, in the future, thinking about maybe making it a little bit more, for their time that they're investing into this. Yeah.
Yeah, it actually isn't that time consuming. I think I timed doing the surveys. Each survey set, you have a week to do it. You do it on your phone. It's over Qualtrics, and it takes less than 15 minutes. So they get $10 per survey they finish. So that's $50 total. So it's not, yes, I would love to do more, but I also want to make sure I can collect enough data. And maybe that'll help my participation. People are signing up, though. They're just not coming to the sessions. And they're filling out the surveys. They're just not coming to the sessions.
Hello? Oh, okay. So I'm sorry, I didn't catch your name, but my thoughts around the storytelling for Latinx students, myself being a first generation Mexican American, like storytelling is huge. And I was wondering if there's going to be a survey on understanding the parents' point of certain storytelling. Because I recall like a lot of scary stories that were told to me, but part of it was about like keeping us in order and making sure we don't get in trouble. So maybe is there any considerations in exploring with the parents the purpose of their storytelling and the impacts that, you know, the children may have?
Yeah, that's something I ask open-ended and then also directed. So I ask about, tell me a story you've told your child about, for example, a significant transition in your family's life. And then I ask, why did you tell your child that? And then I follow it up with, was it to help them process? Was it to share information? Was it to gossip? Or so I ask open-ended and then more directly. And then I also ask, how did you think your child felt when you shared that story? Because I totally agree. My specialization in this sense is with actually like Asian populations, was something I studied for my qualifying exams, but that's an instance where parents might share stories to shame, but like to promote. So thank you so much for that question.
Thank you, everybody. Our last question right here. You're our closer. No pressure.
So I wanted to talk to two people. I'm sorry, I don't know names. For my pediatrician, as a family medicine resident, I don't know how you do this, and I wanted to support you. I know you've had a lot of difficult questions. Seeing patients for me is already burnout, and for you to take on this and to take it on, again, inside I want to just say family medicine, you know, treating everyone. But I am curious and excited that you're collaborating with other people so you don't burn out in this, and so that you can work even maybe with storytelling, you know, on the emotional regulation side, to do this. And then for my psychologist, I'm curious, what are you going to do with these stories? Stories are data, stories are power. Are you going to collect them? Are you going to share them? Like, how are you going to use these stories beyond just the research?
The question was how I'm not burning out. I actually had really bad postpartum depression with my first child, and I have found that this project has been very cathartic and helpful, actually, because I lead the sessions. So it took something that I felt helpless during the pandemic and burnt out and horrible, and it's making it into something productive in my eyes.
Yeah. So how I plan to handle the data, I totally agree. Stories are so rich, and that's what was attractive to me, is how, yeah, the depth of data you can get from a story. So I would love to do something more qualitative where I'm reading the stories and looking for common themes. So similar things that families are talking about, and in that way, to me, this is very like exploratory, or I'll let the data tell me what it has to tell me. So yeah, the plan is to read the stories, identify like maybe commonalities between stories, and really think about what might be helpful or supportive in sharing these stories. Or yeah, I love the question of like, what's the motive behind families doing this? So yeah, I would love to take a more kind of qualitative approach to the data. Thank you so much.
Thank you. Let's all put our hands together, give a round of applause to our presenters. Thank you also to our panelists. We're going to transition very quickly to our next presentation, but I heard a rumor, something about free cruise vacation tickets. Everybody look under your seats. Maybe they're there.
to say you all are amazing. I think you may be plants though, because you have like brought this next workshop. You talked it up. It's going to be perfect with our pilot awardees and the research that they did and all the amazing questions that you asked from the community. We are wanting to, I won't steal your thunder, I promise, but we are wanting this. We are wanting more of this where we have our researchers talk about their research methodologies, and before they actually go out and implement into the community, we have community give input and help them shape and ask these questions before they go out, so they really, really are prepared and well-versed to be able to go out and engage these communities in an appropriate way and be able to get the information that we're seeking so that we can affect change and make impact. So I would like to introduce Dr. Joshua, I'm going to say it correctly, Leonshenko. And Joshua is a medical anthropologist and a postdoctoral scholar in the Department of Social Medicine, Population and Public Health. That's my department, so shout out to my department. And he's within the School of Medicine. His research interest, is trans, non-binary, and gender expansive health and community activism in Southern California, specifically studying how trans clinicians shape the provision of gender-affirming care. So I'd like to welcome you up, Joshua, so we can talk about community engagement studios. So please listen up, because all of you can participate and play a part in this, not only today, but then here afterwards. And we want you to encourage others to come and participate in these community engagement studios.
All right. Can you all hear me? Are my slides up here yet? No? Oh, perfect. It's not break time. All right, hello. Thank you so much for staying in this late hour in our symposium. Can you all hear me okay? Perfect. Thank you so much, Michelle, for that kind introduction. Like she said, I work in HDR. I'm also an SMPPH in the School of Medicine. I lead our Community Engagement Studio initiative, and together with our team in CDC, we've been reflecting on the studios that we've been running for the past 4 years or so here since the founding of the center. From our accumulated knowledge over the past few years in putting on these studios, as well as helpful feedback from studio participants, both researchers and members of the community who have so graciously lent their voices to us, we have begun a new campaign to spread awareness of this unique method that invites community members to be a part of the innovative and groundbreaking research at UC Riverside. Many people see these words and they hear the phrase community engagement studios, often are quite perplexed. They wonder, what does that mean? I know when I first heard the phrase community engagement studio being thrown around, when I started working with HDR as a graduate student researcher before finishing my dissertation, there was a few months I had no idea what it meant. And there was a lot of mystery surrounding it for me. So I think it's the word studio. The word studio often confuses people. So I really want to demystify what this means for all of you. I want to explain what this method entails, as well as provide a space for everyone to ask questions and to really understand how they can be a part of research that is not only for community, but also informed by community. So what exactly is a community engagement studio? This is a consultative session between UCR researchers and community stakeholders that is facilitated by a team from the Community Engagement and Dissemination Core in HDR. The purpose is to connect community members to researchers that address health disparities in their work. The sessions are intended to ensure research projects are informed by community voices, concerns, and interests. So why involve community? I think that a lot of times when we think about research, we often think about it as being this endeavor from the academy, and communities that are invited to participate in research as participants as often are considered to be sources of information extraction points. And we really want to turn the tables and to reimagine how we think about doing research in ways that are more responsive and more responsible to the communities themselves. So community input can impact research in the following ways. It can assist in determining priority research topics. So by listening and being responsive to the communities around us, we can learn more about what they think is worthy of research, as opposed to us as academics and researchers and scholars imposing our will upon them. Increasing the relevance that research has to patients and communities, so making research come alive, make it more real, make it more impactful, as opposed to this inaccessible, data and knowledge that often exists behind paywalls on the internet, making research more integrated within communities. It can also work to strengthen recruitment and retention efforts within a research endeavor, as well as increase dissemination and uptake of research results. So thinking of new, creative, and groundbreaking ways that we can spread the knowledge that we're creating in the School of Medicine, and making sure that it's returned to the communities that have so graciously shared their voices with us. Next, what types of projects have benefited from the Community Engagement Studio? As I previously mentioned, we've had the opportunity to run 4 of these studios over the past few years with HDR. And the topics are very wide-ranging. One topic was on human exposure to manganese in drinking water. Another was childhood asthma. Another was infant feeding practices and early childhood health disparities. And then the most recent was on COVID-19 testing, care, and mobility patterns, which was actually featured in a talk from yesterday. I should note that the manganese project that I cite at the very beginning was actually based on research that took place in the Central Coast of California. So not all research projects that are eligible for a studio here at the School of Medicine need to be Inland Empire or Inland Southern California based. And community expert panels can provide guidance based on project topic or theme, even if the research is being conducted far from where they live. A really important part of the Community Engagement Studio that we've adopted since the pandemic and have just decided to maintain is holding all of them over Zoom. Initially, when we started this endeavor, we were going to be holding them in person. However, the pandemic hit, we all transitioned to Zoom, and we learned that the Zoom format works. Having to schedule with researchers and community members, bringing them together to have a conversation about how their work can be more community engaged, it can be quite a daunting task, and even on Zoom. But on Zoom, streamlines the process and makes it just a little bit easier. So we've decided to continue with that Zoom format. Thus, researchers and panelists really can participate from anywhere, and they're not tied to a particular geographic location. One of the main reasons why I wanted to give this talk today was I'm tasked, my job here at HDR really is encouraging and pushing for more engagement with the Community Engagement Studio method as a form of informing research. So you've all probably saw me at my table in the food room. Thank you so much for those of you who came and spoke with me. I will say it's very difficult to summarize this in 30 seconds while you're trying to get food and everything. So I really do appreciate you listening to me to my 30-second elevator pitch. So I'm really grateful that I have this time to go into a little bit more detail and hopefully answer some questions. But we want to recruit researchers, and we also want to recruit members of the community to be a part of these studios. So UCR faculty members, postdocs, graduate students, or researchers with an ongoing project that addresses health disparities that would benefit from some type of community input may request a studio. Studio requests will be evaluated by the Community Engagement Studio Facilitation Team, which is comprised of myself as well as other members of the Community Engagement and Dissemination Core. And a decision to move forward with the studio. So after examining exactly what the project entails and what the researchers' ideas for community engagement might be, when we make a decision regarding how fit it is for a studio session, and we make that decision and contact the research team within a 5-day period. This service is at no cost to researchers. So this is a service that we provide through HDR, and it doesn't cost researchers anything but their time and willingness to work with us and community members. Next, how can I participate if you're not a researcher? If you are a community member or stakeholder with knowledge and expertise that would benefit research projects, you may sign up to be a community expert panelist. So if you are a patient or family members or caregivers in proximity to individuals or to communities that are experiencing health disparities, advocates from within communities or for communities, residents of particular communities, cities, towns, neighborhoods, regions, or anyone else impacted by a given health issue, either personally or again in proximity to, may be a member of a community stakeholder advisory panel that we refer to as the community expert panel. The word expert itself sometimes makes people a little bit nervous. Oh, people will think, I don't have a degree in this topic, or I don't have credentials to speak on behalf of this other topic. It's not about having some official type of knowledge that is regulated by academia or whatever. It's about having knowledge that is community-based, community-oriented. Community expert panelists will also receive an honorarium payment for their participation during the Community Engagement Studio. So not only is it free for the researchers, but members of the community that agree to be on these panels are compensated financially for their time after the studio process is concluded. So at HDR, we respect that the word expert exists beyond the academy, and expertise includes knowledge gained through lived experience. Community engagement studios are designed to center community voices as an integral part of the research process. Again, attempting to remove research objectives and research interests from within the supposed ivory tower and really bringing this work down to earth, bringing this work into communities, making work and research and knowledge about health disparities accessible in ways that can be applied and can also transform lives. This chart, I have a few charts, so bear with me. I have two that will hopefully describe the process in greater detail. So this chart will show you the Community Engagement Studio process from start to finish, so going from left to right. First, there's the request, and I will provide a link to our request submission page at the end of my presentation today if you haven't already accessed it through our handout that we have in the food room. But these requests can be categorized by pre-research, research design, implementation, analysis, dissemination, or ethics. So research endeavors that focus on one of these areas in the research process. In the planning stage, after receiving that request, we will then engage the facilitator. Now, originally, we would recruit an outside facilitator to come in and be the intermediary during the studio session between researchers and community members. Since I've taken over, I am now the permanent facilitator of sorts, and I work with the rest of the team at CEDC to manage these sessions and to moderate the conversation. During the planning, we will define goals, identify the panelists, as well as coach researchers. So researchers will send us PowerPoint slides. They will send us their proposals, a presentation of their research, and we will provide some feedback. We might request some edits to make sure that what's being communicated to the community is accessible and is understandable and will be productive for the studio session as a whole. So in the preparing of the presentation, we will work to refine questions. We will finalize those questions and then confirm logistics. The CES team, myself and the other folks at CDC, will coach researchers. We will recruit panelists, schedule, and then the potential panelist pool traditionally comes from community organizations, clinical settings, advocacy organizations, faith-based networks, or social networks. Also, if you came and had a conversation with me in the food room, you know that we were also recruiting a potential pool of panelists. So something that we were doing in the past is that we would just take advantage of our existing networks as a center to help us locate potential experts. We have a community advisory board with the CEDC that we would often ask to provide us with names of people that might be able to provide feedback and commentary on projects. And we will still do that. We will still engage our CAB members in order to find experts, but we also want to continuously create a pool of experts so that when we receive a request, we already have a list of names. That's why if you filled out our forms or we're asking about your interests and your expertise, we can then match you with a project when one comes up. So this is a really great way of quickly getting from request to studio date in as little amount of time as possible. Our hope is to be doing several of these per year. And so by having that pool of panelists, we're able to turn this around quite quickly. So during the actual community engagement studio meeting, there'll be a short presentation from researchers, a facilitated discussion that I facilitate as a moderator. Other members of the CEDC are present taking notes. And then at the end of the conversation, the end of the session that typically lasts around 2 hours, the community panelists themselves will provide some evaluation through evaluation forms. And then the rest of us at CEDC take all the notes from the session itself, we examine the evaluation forms, and we draft a report for the researchers. That report is then given within about 2 weeks to the researchers themselves, and then they can use that to then better inform their research, better inform their work, whatever it might be that they requested the studio for, whether it be retention or recruitment or ethical considerations. We gear that report to their concerns, their needs, and interests. This chart is another chart that you might see on our website, so I wanted to talk about it briefly. It's basically the same chart that you saw before on the previous slide, but this kind of shows how there is a lot of work happening behind the scenes simultaneously. So you see there's the request, and with that request, we are working with researchers as well as working with community members simultaneously at the same time behind the scenes, doing all that groundwork, doing all that logistical work to ensure that the studio session itself will run as smoothly as possible. Many of the outcomes that you'll see here, oops, I clicked the wrong one. I'm looking at slides that I think are being projected and they're not being projected, so forgive me. Faux pas. So you can see this chart here. It is somewhat similar to the one that you just saw. It just shows the simultaneous operation of how things work with stakeholders, these community panelists, and the researchers. On the left-hand side, those outcomes that we're looking for at the end of the studio itself, changes in knowledge and attitudes, having more patient and community-centered approaches to doing research, as well as dissemination of research. Stakeholder outcomes, allowing for community members to have their voice heard. I can tell you from personal experience and watching the studios take place, community members absolutely love this. These are people that have been recruited. They're everyday folks that have knowledge, embedded knowledge in where they live, and they're so grateful that people actually care what they have to say because they care so deeply about the folks that they serve in their communities or people that they are representing. On the next slide, time commitment. And I'm quickly running out of time, so I'm going to try and go as quick as possible. Time commitment, this is kind of what everyone's wondering about beyond the cost or honorarium. For researchers, the request process takes around 15 minutes. We have a planning meeting with the CEDC team about 1 hour. You are then tasked, researchers are then tasked with preparing a presentation, which would take about 1 hour, create some PowerPoint slides. We then ask that researchers will edit those slides or make modifications to make them as useful as possible. And then eventually, this all culminates in the 2-hour Zoom session with the community panel. Community experts will have an orientation and training session that will last 1 hour on the same day as the community engagement studio itself. So we meet earlier in the day, and then we have the community engagement studio session. We also add in some time for a break, so not everyone's just sitting on Zoom for straight 3 hours. And then after the actual session, we ask everyone to complete an evaluation form electronically, and that is what's used to then generate the report. On the day of the studio, presentations, guided discussion by community experts, evaluations, and then eventually within 2 weeks that report is sent off. I really imagine this talk to be an invitation to collaborate. It's how I wanted to gear it. It's how I wanted to frame it. And we have so many resources in the food room. We have paper versions of this. However, these QR codes can also link you directly, and Selena's waving them right now. So if you want a paper version of a community panelist pool contact card, please take that. Or if you know someone who might want that, please take it and give it to them. Or you can just share the link with them as well. If you are a researcher and you're interested in allowing us to help make your work more community engaged, that QR code on the left for you. If you are a member of the community and you are interested in perhaps lending your voice to research and making it more responsive to you, to your family, to your friends, to those that live around you, to communities that you care about, please use that QR code or wave down Selena and she'll provide you the paper copy. And if you have any questions, by all means, feel free to find me. A special thank you to Michelle Burrows, Catherine Rodriguez, Selena Hernandez, Zahar Forzan, for all your support and hard work in making this possible. I know I'm the one that's giving the talk today, but like this talk and the studios themselves would not be happening without everyone else that works around me. I'm just right now the face of it, but I'm not the only person that is involved in making it all happen. So I definitely want to acknowledge everyone who is involved. Lastly, if you have any questions, my email, as well as Catherine Rodriguez, our program manager's email, is right there. And I think we're almost out of time, but do I have time to take a couple questions? Yes. Yes, question. Do we have microphones? Do we need microphones? Oh, here's one. So I would be unable to speak on that topic. Does anyone have a question about community engagement studios?
Yes. Hello.
Hi.
How does it work if a community group has a project that's looking for a research and an evaluation team? Is that something that you...
Yeah, so it's kind of the reverse of that.
Yes.
Unfortunately, it's not how it's set up. It's more about the requests coming from the researchers themselves. I think that, yeah, unfortunately, it's the other way around.
The other way around.
Yeah.
So you have researchers that are looking for community agencies to engage with a particular population, and what we signed up for at your table was to get listed.
Yeah, so if you provided your name and contact information in your areas of expertise, so you're going to be in our pool of contacts that if there's a request with a project that comes into our inbox and that project's themes intersect with your expertise, we'll then contact you and ask if you would be interested in serving on the community panel.
Mm-hmm. And your researchers are UCR? Yes. Grads or postdocs?
Yeah,
okay.
Members, yeah.
Oh, okay, great. Thank you.
You're welcome. Thank you. Other questions? Yes.
I would point out, though, if you have a topic that you think deserves attention from HDR, you should contact us because we can match you with researchers who can help, and we can probably, in many cases, actually be a good motivator to start a project. So I don't want to let that go because we've really benefited from that kind of input.
Yeah, that's something that we can receive through the Community Engaged Studio. So definitely.
So the other way, meaning the community themselves?
Yeah, we would like to hear. Yeah. I mean, we would. We would like to hear from you, your ideas, because it can inform some of the research that's already being done, and maybe some of our scholars haven't thought about,
Right. Our project is 5 years old. I'm just developing, I'm going to recruit a new research team and a new evaluation team. It's state funded. Yeah.
I'm sorry, you have a research project.
I have a research project.
I'm sorry.
And I'm asked, that was my question. Could I present use the opportunity to present it to UCR and see if there's some synergy there?
Yes.
Okay,
yes.
Thank you.
I completely misunderstood your question. I sincerely apologize. Of course, yes. Good. Other questions? Yes. Sorry. Thank you.
All right, thank you. It's more of a comment. Dr. Penny earlier talked about how a lot of agencies were giving out a health equity statement, and then it kind of fell flat. I think it's really interesting that UCR has this health disparity research center, but we also need to acknowledge how research has been detrimental to people of color, and addressing, you know, the aftermath and maybe some of the hesitations for folks wanting to participate in research, that there could possibly be an opportunity to have a reconciliation statement that acknowledges how research has been painful and how the folks at this center plan to do it better, mindfully, more ethically. So, you know, I just thought, you know, it's really cool that there's studios, but even strengthening the commitment to serve people, especially folks who don't understand the benefits of research, not interested, like it's not always that exciting unless you're getting paid or there's something in it for you. We would like to think it's for the greater good, which it is, but the folks want to know how it's going to impact them directly. So a reconciliation statement can really strengthen all the work that you guys are doing here.
Thank you so much for that suggestion. It's a wonderful suggestion. Yeah, fantastic. Thank you so much. And I think we're moving on to our next talk.
Who are doing all the work, and they're familiar with some of the community needs, probably more so. But this would be such an added benefit because we have been doing the work. I no longer do it. But being able to collect that data and to put it in context that we can then utilize it on a broader base, well, we need to see your faces in the community. I want to give credit to Tanya because I have invited her into the community. She is present at every meeting. Every time we gather, Tanya's there. Thank you.
Thank you very much for that comment. And yes, I completely agree. Thank you.
And thank you for being on our advisory board too, because in person, yeah, I know. But this is so important because I think there always is that town-gown separation, and part of the mission of the center, we require every one of our projects is required to have a community engagement component. And I think that that's exactly to that point. We have to be out there.
No, thank you. So our closing remarks will come from our distinguished City Council member, Clarissa Cervantes. She is a mother, a long life Riverside County resident who has devoted her career to empowering working families, fighting for social justice, and increasing participation in local, state, and national government. Clarissa helped residents create and develop innovative neighborhood projects, solve problems, and navigate City Hall while working to improve projects and the quality of life in Ward 2. Her extensive legislative and community experience at Riverside City Hall and beyond give her a unique perspective of policy, labor relations, community building, and understanding of how to deliver lasting results for the neighborhood within Ward 2. Clarissa was sworn in on July 13, 2021, and she was elected to represent Ward 2, the second Latina and second openly LGBTQ plus elected on Riverside City Council, making this election a historic win for the city of Riverside. I'd like to welcome Councilwoman Clarissa Cervantes.
Can you all hear me? Yes, I can hear myself. Hello, good afternoon, almost good evening, but thank you for that introduction. And I want to thank you all for taking the time to be here today to come and listen, to soak up the information, the education, to provide valuable input and feedback. And what I wanted to close with is to share how, well, I'll give a little bit of background about myself, and then I'll share what some of my thoughts were about the symposium and how we could all work together to continue this great work forward. Just to mention, I found very interesting as I was going through the agenda some of the conversations that took place today, and just want to share I was born and raised, as you heard, in Riverside County, and I actually grew up in the Coachella Valley. So I grew up in Coachella before it was Coachella. And so I grew up literally with my grandparents having a mobile home at the Salton Sea. So it's fascinating. And back that time, I want to share some 1990, baby. When those conversations were happening, my father actually worked with the Cabs-Lambada Mission Indians, and he was one of their policy directors. And back then at that time, the tribal groups were trying to have conversations about cleaning up the Salton Sea. Look where we are now. And back then, the conversations, I want to let you know, were constantly, no, it's not going to happen, not in this lifetime. And again, I'll say, look where we are today. And I want to mention that partially how we're able to make stride and change, and what I do believe is dependent on who you elect into office. We have had tremendous and incredible change in the Coachella Valley with our elected officials, and I know Assembly Member Eduardo Garcia has been passionate and has made it a personal mission of himself and his office to make that a priority. And so I want to acknowledge the work that their office has done to assure that researchers in these conversations and these partnerships could thrive, so that we're having these discussions and these impacts about the communities that are affected today. Another thing that I found interesting was there was a mention of COVID-related stress and mental health problems. And most folks probably don't know this, but the City of Riverside actually approved over $1 million of funding with various funds that we had to be able to provide access to COVID health centers so people could get tested, so people could have access in neighborhoods where we were not seeing that they felt they had access to. We extended hours, and we had to do the work to make sure we were provided materials that were in various languages. And so there are a lot of things that your city government can and should be doing to assure that all groups and all people have access to these types of whatever health issues it is that we're facing at that time. One thing that I found also interesting as I was going through here, and I thought people would find maybe interesting to hear about, but I noticed that there's some research done on the socio-cultural and emotional regulation processes impacting Latinx children. I represent, and I'm very proud to represent, the Eastside neighborhood. The Eastside neighborhood is just a block away, right? You go past Chicago Avenue, and we have Eastside residents and folks I know here in the house. But I just want to share one thing that I'm very passionate about. And when back in 2013 and 2016, I actually worked for the previous council member. And when I was a field representative, one of the big initiatives that took place in the East Side was the East Side Heal Zone, the Healthy Eating Active Living Zone, and it was funded by Kaiser Permanente. And it was $1 million that came in to fund and transform how residents were able to have access to healthy fruits and vegetables. How were we going to address the rise in the diabetes and the cholesterol, blood pressure, and the other issues that we were seeing across neighborhoods, but specifically in this neighborhood that is identified as a disadvantaged community. And one of the items as well, and a lot of people don't realize, but in the 12th largest city in California, we still have food deserts in the heart of our cities. And so I am a representative of a food desert community that we are still trying to find opportunities to close the gap so that everyone can have access and make sure that they can have a well-rounded life for their family. So initiative that my office took up actually as soon as I came into office, I was inspired by a project in Oakland, and this was founded by a Black and brown LGBTQ couple. They have a farm up in Oakland called Black Brown Farm, Girl Farms, And they started growing organic produce. They then partnered with the local chef who started making meals, and then they started distributing them to community who were in need. We decided to create a pilot project that replicated that here in Riverside, and it was called Farm to Fork. We partnered with Molina Healthcare, the UCR Community Garden, and the UCR Community Garden has since last January grown thousands of pounds of food, which we then pick with members of the community. We then package them. We actually work with another local business called Tradish, and Tradish then cooks healthy meals with those vegetables. We put together recipes, and we then drop those off to 50 identified residents and people on the east side who have signed up to the program or that we have been recommended through our facilities such as Riverside University Health Center systems or through Riverside Community Health Foundation. And from that, we've had great response from residents in the community who have received access to it. But we've also heard from other cities in the area who've said, how can we do what you're doing? How can we get a part of this or be involved so that we can continue to expand this opportunity so that we could be involved? And another item I want to share, I'm a researcher. I'm finishing my master's in urban regional planning at Cal Poly Pomona. And my research actually explores how art has an impact in local neighborhoods and how specifically community murals that are driven by community engagement and storytelling, how those have a positive impact. And just this last week, the City Council, I drafted a pilot proposal, and it's the first ever artist in residency. And it was approved by council last week, which I'm very excited about. Thank you. It took a year for me to get that through to get passed, so it was a little bit of a heavy lifting. But it will do is it will create 6 artist positions that will pay them $20,000 stipend. They will then be assigned to work in a community, and get this, one of the requirements is community engagement and making sure they meet and hear with residents. But the goal is for them ultimately to have 7 new murals that would go up across each ward in the city of Riverside. So at the end of the pilot project, we would have 3 artists who were paid a stipend of $20,000 each. You'll have 7 new public art installations, and all of them driven with community engagement and storytelling to uplift the communities that live in those neighborhoods so that we are creating communities of belonging, of healing, of acceptance. And that is what we need to see in the city, is for people in the neighborhoods. And this is where I was going to say my office comes in play. When we work with UCR, when we work with RCHF, when we work with RUHS, my role is to listen. And my role is to take with individuals like yourself who say, we have a problem in the community, we have a need, and we need to learn how to address it. And we come in. And then we help to find, again, the partnerships. And I like to sometimes tell people, I feel like my job that I was elected to do, because so many people come in and ask to meet with me. I meet with hundreds of people in just 1 month. All those meetings add up to me having all these pieces of people who work across our city, who serve in different ways. And then when one person comes in and says, Councilmember, I have a problem and I haven't been able to find the source, I know exactly who to direct them to. Or I say, I know exactly who's working on the issue you're working on, or I know exactly who's passionate about the item that you have concerns about. And then we pair them together, and it feels like we're healing a big puzzle piece, and we're piecing together and connecting people, finding solutions, changing lives. And that's really what I want to do, is if there's even one life that we can improve, one person's life that I can go to bed and know we made their life easier, we're doing something right. And so I want to thank all of you for dedicating your lives, your research, your careers, giving your time. I know that these things take time from family sometimes and friends, but when you're passionate about what you do, when you care and when you show up with intention, when you listen to people, when you ask questions, you can make a huge difference. And I think I love coming to events like this, symposiums, where we're able to gather together, because I can feel, and I know in this space, we're working towards something that's a collective, that's powerful, and that can ultimately change our neighborhoods. And that's what I'm here to do. So if you ever need a friend at City Hall, or if you ever want to share an idea with me, if you're ever looking for researchers or people to invest in your projects, we work with many of our neighborhood groups who have said, Councilmember, we have an idea, we just don't know how to fund it, we just don't know what to do about it, and we're usually almost always able to find a way. So where there's a will, there's a way. And I'm going to leave with this. I believe there's a quote that Maya Angelou says, and that is, your legacy is every life that you touch. So I wish you all a wonderful and powerful legacy. Thank you.
So Thank you, Councilmember. Thank you very much. Again, thanks to all of you for coming. It's been a wonderful 2 days of conversations, discussions, really fantastic presentations. I have so many more questions to ask. I'm not sure what else to say, but this has been really wonderful. I'm so glad we all got together in person and had a chance to really chat and share food and drinks together and everything like that. And I hope to see you soon. Not wait till the next meeting, because we have so much more projects that are ongoing, so much work to do, and so many more conversations to have. So again, thank you all for coming. This has been excellent. So have a good day. Have safe travels. And thanks again to Michelle, Catherine, Selena.
Yes, so thank you all for coming and participating, lending your voice. I hope that this is not the last time that we join together. We want you, we need you to collaborate to make a difference in the Inland Empire. So thank you again, and have safe travels home.